Intensive care units IQs represent a triumph for medicine, the ability to support and replace a large number of bodily functions. And yet, these actions are not cost-free. Nearly every intervention has side effects and risks, all of which must be mitigated. While rapid decision-making is often possible and desired in the management of emergency center or ward patients, this approach can be prone to errors in the ICU environment and must be used in the appropriate clinical situations. In much of academic medicine, there are two overarching approaches to patients, those being a problem-based approach and a systems-based approach. In the ICU, the systems-based approach is preferred because of the need to thoroughly consider the patient's needs and status from every angle. And this too is the layout of this chapter, covering each organ system and their common dysfunctions and treatments. In the United States, critical care medicine has numerous educational pathways to include surgery, anesthesia, and internal medicine fellowships. Similarly, many larger hospitals have separate ICUs focused on patient subsets, cardiothoracic ICUs, medical ICUs, neuroscience ICUs, surgical ICUs, transplant ICUs, etc. Other smaller hospitals dispense of any such distinction. Each specialty brings a unique perspective. Surgical critical care, John P. Sadie, VAMSI air binding, S. Robt, renal system, hematologic, endocrine, glucose, special aid, the open app, an advantage to the field of critical care medicine. Surgical intensivists possess a strong grasp of the expected course of surgical diseases as well as comfort with many commonly needed procedures such as bronchoscopy, esophagogastric duodenoscopy, percutaneous tracheostomy, etc. Finally, it must be emphasized that providing quality ICU care is not solely dependent on the intensivist, but also on the entire multidisciplinary ICU team. To the greatest extent possible, joint guidelines and standardization of care in conjunction with nursing, pharmacy, physical therapy, respiratory therapy, and other members of the healthcare team should be developed. It is well documented that this standardization of care improves outcomes. Although exceptions may exist to every guideline, having standard processes with the ability to adjust improve the quality of care. These guidelines are often unique to an institution based on best evidence and local expertise, capabilities, etc. Neurologic system. Pain and agitation. Pain is a ubiquitous but often unrecognized and inadequately treated symptom for the critically ill patient. In the ICU setting, TIAN, mechanical ventilation, invasive lines, etc. Pain is a source of fear and anxiety that, if not properly addressed, contributes to physiologic alterations that can negatively impact patient outcomes and delay recovery. Although the sensation of pain is subjective, there are several measuring tools and scales to quantify pain as an objective data point that can be treated and easily reassessed for improvement. In patients who are able to communicate, the visual analog scale and numeric rating scale are used and provide reliable means for assessment and treatment. However, non-communicative, altered, or comatose patients must rely upon the observing and attentive physician or nurse to identify the visual cues and physiologic alterations, for example, tachycardia, hypertension, tachypnea, diaphoresis, etc., that coincide with uncontrolled pain. If objective data are unavailable, one is better off to presume the presence of pain and provide appropriate treatment. Opioids have traditionally been the first-line therapy for pain as they are centrally acting, highly effective for non-neuropathic pain, have a rapid onset, and can be administered via multiple routes, enteral, intravenous, transdermal, etc. Unfortunately, opioids are often overprescribed, leading to untoward side effects, patient abuse, and addiction. Deleterious side effects including nausea, vomiting, pruritus, sedation, respiratory depression, and bowel dysfunction result in unnecessary complications, prolonged hospital length of stay, and increased morbidity. Prolonged use can also result in physiologic dependence, tolerance, and opioid-induced hyperurgia. Enhanced recovery after surgery protocols and the practice of utilizing multimodal therapies that work synergistically to alleviate pain and provide sedation are paramount in combating the opioid epidemic that currently plagues the United States. Combining the ability to perform regional anesthetic blocks along with non-opioid adjuncts with varying mechanisms of action such as acetaminophen, non-steroidal anti-inflammatory agents, gabapentinoids, tramadol, and muscle relaxants results in more effective analgesia and lower overall opioid requirements. The use of multimodal pain medications has become the standard of care to reduce opioid reliance and should be implemented widely. In the same manner that pain is assessed and treated, agitation is quantified using various scoring systems to include the Richmond Agitation Sedation Scale. When a patient is agitated, it is important that a thorough assessment of any underlying treatable etiologies is completed prior to initiating a pharmacologic intervention. Clinical guidelines have been recently updated and published by the Society of Critical Care Medicine as to the management of the agitated ICU patient. The most commonly used sedatives in the ICU include propofol, benzodiazepines, and dexmedetomidine. When deciding on which agent to use, considerations must include the expected duration and depth of sedation required, comorbidities, which may affect pharmacokinetics or metabolic clearance, and potential drug interactions with other medications the patient may already be receiving. Propofol is a highly protein-bound, lipophilic molecule that is frequently utilized in the ICU. The exact mechanism of action is not fully elucidated, but it is thought to potentiate gamma-aminobutyric acid GABA receptors resulting in amnesia but without analgesia. Because propofol is highly lipophilic, it readily traverses the blood-brain barrier and results in rapid onset of action in less than 1 minute as well as a short duration of action as it is quickly distributed into peripheral tissues and readily metabolized by the liver. Rapid clearance of propofol makes it the ideal drug for daily sedation weans to assess a patient's neurologic status. Hypotension. Serious potential side effects of propofol infusion include pancreatitis, hypertriglyceridemia, and propofol infusion syndrome. Propofol infusion syndrome is a rare complicated ion associated with prolonged and/or high doses of propofol administration that is thought to be caused by mitochondrial respiratory chain inhibition or impaired mitochondrial fatty acid metabolism. Clinical features include bradycardia, rhabdomyolysis, hypolipidemia, hepatomegaly, and renal failure. Early recognition is critical because it has a high mortality rate and treatment is fairly limited to supportive care and discontinuing propofol administration. Benzodiazepines are GABA receptor agonists that produce anxiolysis at low doses and sedation, amnesia, and cardiorespiratory depression at higher doses. The most common benzodiazepines used in the ICU setting are midazolam, lorazepam, and diazepam. Both midazolam and lorazepam can be administered as continuous infusions, whereas all three can be administered intermittently and have rapid onsets of action. The duration of action for each of these drugs is relatively short on initial administration as they are lipophilic and readily distributed to peripheral tissues. However, repeated administration or prolonged infusions result in saturation of adipose tissues and prolonged sedation even after discontinuation. Age, obesity, and altered hepatic or renal function all can alter benzodiazepine clearance and must be considered when deciding on the appropriate medication. The side effects of benzodiazepine administration include cardiovascular and respiratory depression, delirium especially in the elderly, as well as propylene glycol toxicity. Propylene glycol is used as the solvent for Roman-4 lorazepam and diazepam, and toxicity is rare. It is characterized as an anion gap metabolic acidosis, renal failure, and eventual multisystem organ failure. Treatment is limited to dialysis and discontinuing the offending agent. Dexmedetomidine is a centrally acting alpha-2 adrenoreceptor agonist that binds to receptors within the locus coeruleus to provide sedation and anxiolysis and receptors in the spinal cord to provide for analgesia. It has a relatively quick onset of action between 5 and 15 minutes and a duration of action between 60 and 120 minutes. Dexmedetomidine is hepatically metabolized by glucuronidation and the cytochrome P450 system, and, as such, alterations in dosing may be required when other cytochrome P450 altering medications are being given. One of the main advantages of dexmedetomidine is that it has no effect on respiratory drive, so patients can be sedated without the need for mechanical ventilation. Studies have also demonstrated that dexmedetomidine usage results in extubation almost 2 days sooner compared to midazolam use. The adverse effects of dexmedetomidine use include bradycardia, hypotension, atrial fibrillation, and reflex hypertension with abrupt cessation of administration. Currently, the U.S. Food and Drug Administration FDA states the use of dexmedetomidine for initial sedation should be limited to 24 hours with the idea that prolonged use can exacerbate reflex hypertension when stopped. It is not uncommon for ICU patients to receive continuous infusions of sedatives as it increases patient comfort and provides a reliable and consistent level of sedation. That being said, randomized trials have demonstrated that protocol-driven daily sedation interruption decreases the duration of mechanical ventilation and length of stay in the ICU and improves the ability to perform daily neurologic assessments. Sedation holidays are also cost-effective as they decrease amounts of Medicaid ion administration and reduce unnecessary diagnostic testing obtained to evaluate a patient's neurologic status. Tau status is an often overlooked and underestimated aspect of critical care. Alterations in mental status among the critically ill can be hard to recognize and include a spectrum of disorders including delirium, encephalopathy, and coma. Patients who are elderly and those with pre-existing mental illness or cognitive impairment are at increased risk for developing alterations in mental status when critically ill. When a patient has an acute change in mental status, it is important to rule out any organic or potentially reversible causes because the diagnosis of delirium of critical illness is otherwise a diagnosis of exclusion. Some examples of organic causes that can lead to an acute change in mental status include hypoxia, hypercapnia, hypoglycemia, Medicaid ion side effects or withdrawal, infection, metabolic derangements, cerebrovascular accidents, seizures, and changes in intracranial pressure. When a patient becomes confused, they lose their sense of orientation and are no longer able to identify who they are or where they are or will lack a general perception of time. Delirium is defined as confusion along with a disturbance in focus, attention, or awareness that occurs over a short period of time. The delirious patient will also develop cognitive deficits such as memory loss and difficulty with language or visuospatial abilities. Identifying and trying to reverse the effects of delirium are important because those who develop ICU delirium have an increased mortality, residual functional disabilities, and higher rates of dementia after discharge. In general, hyperactive delirium is easier and more quickly detected as these patients are agitated and restless. However, the opposite is true for patients who develop hypoactive delirium as they are quiet, inattentive, and lethargic, which can be easily overlooked and ignored. The elderly and patients with prior mental illness or decreased cognition are at higher risk for developing hypoactive delirium and should be evaluated carefully. Assessment for delirium has been standardized by utilizing either the confusion assessment method for the ICU or the intensive care delirium screening checklist. Both assessment tools have been validated in the ICU setting and can also be utilized for the mechanically ventilated patient. Utilizing either one of these assessment tools on a regular and scheduled basis allows for an objective assessment of a patient's mental status and increases the chances for early detection of delirium. When a diagnosis of delirium has been established, prompt intervention is important in order to begin the process of reorienting the patient and identifying any precipitating factors. The basis of treatment includes identifying and reversing any potential organic causes and providing supportive measures that bring the patient's behavioral alterations back to baseline. Supportive measures serve to limit abnormalities around a patient's environment that would not necessarily be present and to provide a calm, secure, and safe environment. Modifiable behavioral and environmental factors include limiting circadian rhythm abnormalities and maintaining normal sleep-wake cycles by opening blinds or shades during the day and turning off lights at night, reducing ancillary and unnecessary noises or noxious stimuli, avoiding the use of restraints when safe, mobilizing the patient, providing the patient with their eyeglasses or hearing aids if needed, and having family or friends help to reorient and reassure the patient. No-onset delirium has been documented to result in a statistically significant increase in the 90-day mortality rate, which increased in a graded manner when these patients were exposed to noxious stimuli, placed in restraining devices, or developed hospital-acquired conditions such as falls or pressure ulcers, altering a patient's environment, and if patient behavior interferes with their care or they are disoriented to the point of potentially harming themselves or others. Low-dose antipsychotic medications such as haloperidol can be safely utilized. Benzodiazepine use should be limited to cases of sedative or alcohol withdrawal as they can precipitate delirium, especially in the elderly population. When sedative infusions are necessary, dexmedetomidine has been found to decrease the rate of delirium by more than 20% when compared to using midazolam, although no one agent is ideal and the proper choice of sedative needs to be made on a case-by-case basis. The medical workup of delirium should include a thorough review and cessation of any unnecessary medications, physical and neurologic examination with possible computed tomography CT imaging of the brain, and evaluation for potential infectious etiologies with sampling of cerebrospinal fluid with lumbar puncture when clinically indicated. If no obvious etiology is found, one must consider magnetic resonance imaging MRI of the brain, electroencephalogram, measuring drug or toxin levels, or prophylactic supplementation with vitamin B12 or folate if there is concern for alcoholism. Often confused with delirium, which describes the mental manifestations of the disease, encephalopathy is a term to describe an altered mental state per the underlying pathophysiologic process. Encephalopathy develops as a syndrome of overall brain dysfunction and can occur from many organic and inorganic causes that directly induce brain injury or remotely affect the brain from other systemic causes. Encephalopathy can be described as acute or chronic based on the timing and potential reversibility of the syndrome. Chronic encephalopathy is slow to progress and results in structural changes in the brain that are usually irreversible. Acute encephalopathy can potentially be reversed with a return to baseline functional status if the inciting insult is removed or treated in a timely fashion. Examples of causes of encephalopathy include chronic traumatic encephalopathy, Wernicke-Korsakoff syndrome, heavy metal poisoning, electrolyte abnormalities, liver failure, medications, and sepsis. At the furthest end of the spectrum of altered mental status is coma. A comatose patient is unarousable and unaware of their environment. Most cases of coma that present to the emergency department are due to trauma, cerebrovascular accidents, metabolic derangements, medications, seizures, and infections. The Glasgow Coma Scale GCS is a neurologic assessment tool that provides a reliable and objective measurement of a patient's conscious state. It is composed of 3 elements: eye, verbal, and motor responses and scaled from 3 to 15. The lowest possible score is 3 when a patient has no response to stimuli, and the highest possible score is 15 when a patient is fully awake and interactive. When comatose patients have a GCS score of 8 or lower, Their brain injury or dysfunction is deemed severe and they should be intubated as they cannot reliably protect their airway. As is the case with most causes of altered mentation, treatment for comatose patients is based on identifying and treating any reversible organic causes and providing supportive care. Traumatic brain injury. One of the leading causes of disability in the United States, traumatic brain injury (TBI) is a devastating and life-altering event that often leads to heavy familial and socioeconomic burden. It is the most common cause of death and disability in people between the ages of 15 and 30, and the most severe cases result in prolonged periods of coma and unresponsiveness. The severity of TBI. Type 5 pathologic injuries such as skull fractures, cerebral contusions, hemorrhage or hematoma, and diffuse axonal injury. Primary and secondary brain injuries are the two phases during which neuronal injury occurs. Primary brain injury occurs during the initial insult, whereas the focus of critical care management of TBI is to limit secondary brain injury. Secondary brain injury is a consequence of pathologic and physiologic alterations that manifest after the initial injury, usually due to concomitant multi-organ injury. Examples of causes of secondary brain injury resulting in further neuronal injury and death include ischemia, hypoxia, hypotension, cerebral edema, acidosis, and elevated intracranial pressure. Management and treatments are focused on optimizing intracranial pressure and blood pressure in order to maintain adequate cerebral perfusion, avoiding hypoxia, and maintaining normothermia and normoglycemia. Often, anti-seizure medications are prescribed as anti-seizure prophylaxis, although the ideal medication dosage and duration of treatment are not clearly established. Recovery after TBI can be a prolonged and lengthy process. Approximately 10% to 15% of patients with severe TBI GCS less than 8 are discharged in a vegetative state, with approximately 50% regaining consciousness by 1 year. Medication adjuncts to accelerate and maintain long-term recovery are sparse. A randomized controlled trial investigating the use of amantadine has shown that, over a 4-week treatment period, patients showed accelerated recovery. However, over the long term, there was no difference between the treatment and placebo groups. Long-term prognosis and recovery are variable and difficult to predict and are highly dependent on the severity of TBI, patient comorbidities, and post-injury complications. Cardiovascular system. Cardiovascular issues commonly encountered in the ICU can be separated broadly into 3 categories: cardiac arrhythmias, shock, and myocardial ischemia. All of these areas are affected in the setting of primary cardiac dysfunction such as heart failure or myocardial infarction (MI) and may be affected by extracardiac disease processes. For example, pulmonary embolism can lead to right heart failure, hypothyroidism can lead to arrhythmias, and increased metabolic demand can lead to cardiac ischemia. This section begins by briefly covering normal physiology, continues on to disorders encountered in these 3 areas and their treatments, and concludes with invasive and non-invasive methods of monitoring the heart and fluid status. Cardiac physiology. The heart is a 2-pump circuit in sequence. All blood that goes out of the right ventricle to the pulmonary circulation must then be pumped out of the left ventricle to the system circulation, with important exceptions that arise in the setting of congenital cardiac anomalies and a minor exception from bronchial arteries and veins. There is a vast difference in resistance between the pulmonary vascular bed faced by the right heart and the systemic vascular bed faced by the left heart, with the pulmonary pressures and resistance being significantly lower. The heart's ultimate function is to supply oxygenated blood to the tissues of the human body. This ability is captured by the oxygen delivery equation. Oxygen delivery equal to cardiac output hemoglobin. Asterisk 1.3 asterisk oxygen saturation plus 0.003 partial pressure of dissolved oxygen. L/minute. Overall, one observation is evident: the primacy of the hemoglobin and oxygen saturation in determining the carrying capacity of oxygen by the blood and the relatively trivial contribution of dissolved oxygen. Vascular resistance is the collective resistance of all vessels including arteries and veins against the flow of blood, and there are 2 such resistances: the systemic vascular resistance SVR faced by the left ventricle and the pulmonary vascular resistance PVR faced by the right. The relationship between flow, pressure, and resistance is defined by Ohm's law. Mean arterial pressure, right atrial pressure equal to SVRCO. Mean pulmonary arterial pressure, left atrial pressure equal to PVRCO. These relationships guide decisions about fluid and vasopressor therapy, which are elucidated later. The lower PVR consequently requires a smaller right heart muscle volume, lower pulmonary artery pressure to supply the lungs with the same CO as the rest of the body. This means that the right heart is unable to maintain a CO in the face of large, acute rises in PVR, and this lack of reserve has significant consequences both in trauma surgery when a trauma pneumonectomy is performed and in thromboembolic disease in the lung. In both these situations, a sudden rise in PVR, particularly in the context of a low preload, can lead to cardiovascular collapse. The heart muscle is supplied primarily by the coronary arteries. During systole, the subendocardial vessels experience retrograde flow, and thus the heart is primarily supplied during diastole. This has important implications for cardiopulmonary resuscitation, as failure to allow for full recoil of the chest may reduce blood supply to the subendocardium during resuscitation. The heart's rhythm is controlled by pacemaker cells. The primary node is the sinoatrial node, which is influenced by sympathetic stimulation from the sympathetic trunk mainly arising from the T1, T4 spinal levels, which stimulate positive chronotropy. Parasympathetic stimulation results in negative chronotropy and is mediated via the vagus nerve. The heart has a series of escape pacemakers, which are, in order, the atria, the atrioventricular node, and the ventricles themselves. As long as the sinoatrial node paces above the intrinsic rate of these escape pacemakers, and as long as those impulses are transmitted through the atrioventricular node and to the ventricles, impulses from the sinoatrial node control the heart rate. Cardiac arrhythmias, supraventricular tachycardias, atrial fibrillation. Postoperative atrial fibrillation is common, occurring in 8% of major surgeries and 45% of cardiac ones. Recent work has noted that the risk of thromboembolism after the development of atrial fibrillation after non-cardiac surgery is similar to that of patients with non-valvular atrial fibrillation. However, while the 2016 European Society of Cardiology guidelines now recommend anticoagulation for postoperative atrial fibrillation following cardiac surgery, they do not address other major surgical procedures. For atrial fibrillation with rapid ventricular response, the acute management is dependent on the hemodynamic stability of the patient. If the patient is acutely unstable, immediate electrocardioversion is mandated as it is for any tachyarrhythmia causing acute instability. In the context hemodynamic stability, pharmacologic, context of heart failure, as it does not depress cardiac function as is done by beta blockers and calcium channel blockers. That being said, a recent retrospective review documented that metoprolol had the greatest success in the treatment of acute atrial fibrillation, defined by rate control without the need for a second agent. Other studies have noted more rapid control of atrial fibrillation with diltiazem in both the emergency department and the ICU, but also noted an increased rate of hypotension with its use relative to amiodarone. More recent data from the emergency medicine literature suggests that procainamide may be an efficacious option for cardioversion of atrial fibrillation out of aggressive protocol. Acutely, Digoxin alone is not recommended owing to its slow onset and comparative lack of success in controlling atrial fibrillation. 2 points of caution should be noted. Traditionally, it was held that cardioversion of an atrial rhythm into sinus could safely occur up to 48 hours after initiation of the rhythm. Thereafter, either a transesophageal echocardiogram to verify lack of clot formation in the left atrium or 4 weeks of anticoagulation were recommended prior to cardioversion, except in cases of acute hemodynamic compromise. However, recent work suggests that the safe period of cardioversion may be much shorter, as little as 12 hours. While all drugs used to treat atrial fibrillation may induce cardioversion into sinus rhythm, amiodarone is especially prone to do so. Thus, it should be used with caution in patients with longer time periods of atrial fibrillation due to its high tendency to result in a return to sinus rhythm. Second, in patients with an accessory pathway, such as Wolff-Parkinson-White syndrome, atrial fibrillation with preexcitation may be better. The use of calcium channel blockers, beta blockers, amiodarone, and digoxin is contraindicated in such instances due to the risk that following suppression of the atrioventricular node, the accessory pathway will result in an exacerbated tachycardia. In this scenario, ibutylide or procainamide is recommended by the most recent guidelines. Multifocal atrial tachycardia. Multifocal atrial tachycardia is most commonly associated with hypomagnesemia, pulmonary insufficiency, hypokalemia, and coronary artery disease or other known precipitating factors. If correcting hypomagnesemia and hypokalemia in that order are not effective, then beta blockers and calcium channel blockers should be tried. Interestingly enough, data show that an empiric push of 6 milligrams of Roman 4 magnesium sulfate terminated multifocal atrial tachycardia 88% of the time, regardless of serum magnesium levels, a result possibly explained by a systemic deficiency of magnesium with normal blood levels. Atrial flutter. Atrial flutter is commonly caused by the same disorders that give rise to atrial fibrillation. It is also not infrequent following the treatment of atrial fibrillation with amiodarone. It is an unstable rhythm and has the potential to spontaneously degenerate into atrial fibrillation or to revert to normal sinus rhythm, particularly if the underlying factors have been addressed. The management of atrial flutter is similar to that of atrial fibrillation, with rate and rhythm control options, but electrocardioversion is the preferred therapy. Antiarrhythmic drug therapy is also an option and may be selected for stable patients who are too high risk to undergo the sedation that would typically be required prior to electrocardioversion. Additionally, ibutylide is FDA approved for the conversion of atrial flutter to normal sinus rhythm and has shown superiority to amiodarone and procainamide in this setting. It should be remembered that points. It must be used with caution in patients at high risk for torsades de points, and patients should be in a monitored setting following its use. Roman 4 magnesium given alongside ibutylide both enhance its ability to break atrial flutter and prevent torsades de points. Paroxysmal supraventricular tachycardia. There are numerous other subtypes of supraventricular tachycardias, of which the most common is atrioventricular nodal reentrant tachycardia. The pathophysiology is a reentrant circuit. While sometimes difficult to distinguish from sinus tachycardia and ventricular tachycardia, blocking the atrioventricular node by using vagal maneuvers can reveal the underlying rhythm. Agents acting at the atrioventricular node adenosine, beta blockers, and calcium channel blockers are all options to terminate these rhythms. It is important to distinguish a paroxysmal supraventricular tachycardia with a block from a ventricular tachycardia, as both may present with a widened QRS. A history of heart disease or operation portends a ventricular tachycardia. Furthermore, adenosine will aid in distinguishing the rhythms, as it will stop a supraventricular tachycardia but not a ventricular tachycardia. Additionally, ventricular tachycardia will not respond to beta or calcium channel blockers. Ventricular tachycardia. Monomorphic ventricular tachycardia. Ventricular arrhythmias are rare in young patients and those without a history of heart disease. Options for treatment in stable patients include lidocaine, amiodarone, and procainamide. These are also adjuncts to consider if initial defibrillation for stable or unstable patients fails to convert a ventricular tachycardia into a sinus rhythm. Additionally, a recent study demonstrated the superiority of procainamide to amiodarone in the conversion of stable ventricular tachycardia. Seeing as procainamide is a therapeutic option for atrial fibrillation with rapid ventricular response, supraventricular tachycardias, and ventricular tachycardias, it may be considered a go-to option if one is uncertain of the rhythm. While some patients with ventricular tachycardia may appear stable, they are at high risk for sudden deterioration and must be monitored closely and treated expeditiously. Polymorphic ventricular tachycardia. Fundamentally, a monomorphic ventricular tachycardia indicates that ectopic beats are rising from one often ischemic focus in the ventricles, typically secondary to coronary artery disease. Polymorphic ventricular tachycardia indicates either multiple foci of ectopic beats or more commonly global dysfunction. The latter is a rhythm classically known as torsades de points, a feared rhythm for which a predisposing factor is a prolonged QT interval. This can be caused by a variety of drugs and by an inherited condition. Ironically, many antiarrhythmics, including procainamide, lidocaine, and ibutylide, prolong the QT interval, as do commonly used antipsychotic drugs such as haloperidol. The treatment is focused on unsynchronized cardioversion if unstable and aggressive administration of magnesium. Bradycardia. While the treatment of tachycardia involves extensive pharmacologic options backed up with electrical cardioversion, the treatment of bradycardia focuses more on electrical pacing, either transcutaneous or transjugular, as well as reversing the underlying cause. Such causes of bradycardia include acute spinal cord injury, MI, hypoxia, and various toxicologic states, as well as global function and sometimes a periodically rhythm. The acute management includes atropine, epinephrine, and pacing. However, these are temporary supports apart from spinal cord injury, and the priority must be reversal of the underlying cause. Sinus bradycardia. Sinus bradycardia may be a normal resting rhythm for many fit, young individuals, and no treatment is required. It may also be seen in profound shock states, as a periodically rhythm. Sinus bradycardia secondary to a spinal cord injury can occur in high cervical spinal cord injuries and should be treated with atropine and concomitant vasopressor therapy to treat neurogenic shock as required. Similarly, sinus bradycardia associated with MI, commonly seen in inferior wall infarctions due to involvement of the sinoatrial node, can be treated with atropine as well. Sinus bradycardia secondary to the use of dexmedetomidine requires a different mindset. If this occurs, treatment of the resultant hypotension with vasopressors is required until the drug wears off, and slash or pacing may be required if the hypotension is significant and unresponsive to moderate vasopressor use. Atropine and epinephrine will be ineffective with this etiology due to the alpha-1 antagonist effect of dexmedetomidine. Junctional or ventricular bradycardia. Junctional or ventricular bradycardia is due to profound atrioventricular node dysfunction. There is no atrial activity apparent. Treatment with temporary pacing may be required if the CO falls. Atropine is not effective in this scenario because it acts upon the dysfunctional atrioventricular node. Shock. The most severe hemodynamic alteration is shock, which is a condition of circulatory failure resulting in end organ dysfunction secondary to reduced perfusion. The shock state itself is indicated by signs of end organ dysfunction such as rising lactate, altered mental status, falling urine output, and liver enzyme elevation. Each form of shock demands different responses, and when different forms of shock are combined, the appropriate management can be challenging. There are numerous forms of shock, classified broadly into 4 categories: distributive, hypovolemic, cardiogenic, and obstructive. Distributive shock, neurogenic shock. Neurogenic shock occurs secondary to the loss of sympathetic tone after a spinal cord injury. The overall etiology is decreased vascular resistance. However, there are two variants based on the location of the spinal cord injury. In lower spinal cord injuries, below C5, the hypotension causes an appropriate reflex tachycardia. In higher spinal cord injuries, C5 and above, the patient is often bradycardic, in that the heart does not respond appropriately to the increased vagal tone due to the lack of sympathetic innervation to the heart. This results in a warm shock. Treatment consists of vasopressor support to maintain blood pressure. While norepinephrine is considered the first-line therapy, no agent has been proven to be superior. Of note, neurogenic shock does not equate to spinal shock. Spinal shock is not a hemodynamic phenomenon and results in the temporary loss of reflexes following a spinal cord injury, most commonly the bulbocavernosus and cremasteric reflexes. It is temporary in nature. Septic shock. Septic shock arises from inflammatory mediators released by the body in response to bacterial or fungal pathogens and is considered a dysregulated immune response. Traditionally, being defined as derangements in 2 or more of 4 parameters: white blood cell count, temperature, heart rate, and respiratory rate. Septic shock was then sepsis unresponsive to fluid resuscitation requiring vasopressor support to maintain the blood pressure. While still commonly used, these definitions have been superseded by new guidelines that base the definition of sepsis and septic shock on sequential organ failure assessment SOFA scores. Specifically, organ dysfunction represented by an increase in SOFA score of 2 or more represents sepsis, while sepsis with hypotension despite fluid resuscitation and / or serum lactate greater than 2 despite a lack of hypovolemia represents septic shock. Previous sepsis management guidelines included immediate lactate measurement and other laboratory values, an empiric 2L fluid bolus, empiric antibiotic administration following cultures being drawn, appropriate measurement and titration of fluid resuscitation to central venous pressure and central venous oxygen saturation, and potentially a Swan gas catheter to accurately capture hemodynamic variables. This was known as an early goal-directed therapy. Subsequent randomized controlled trials suggest that this bundle has no benefit. However, proponents maintain that these studies are flawed and that much of early goal-directed therapy has become standard of care. This issue is even more complicated as many aspects of early goal-directed therapy have been indoctrinated as quality metrics, meaning failure to comply results in the hospital or clinician being penalized. What is widely accepted is that early recognition and administration of antibiotics lead to increased survival, although this must be balanced against the risk of increasing antibiotic resistance and the harms associated with administering antibiotics to patients who do not require them. Early source control of the infection is also positively associated with outcomes. While it may seem logical that vasopressors are the first choice for septic shock, given that the derangement is systemic vasodilatation, this is counterbalanced by the fact that a critical portion of the pathophysiology of septic shock is leakage of fluid into the interstitial spaces due to an increase in vascular permeability. Consequently, increasing vasconstriction alone will not by itself reverse the shock state. Traditionally, fluid resuscitation followed by vasopressor therapy only when fluid is no longer produced. An increase in blood pressure fluid responsiveness has been standard. This is currently being studied in a major randomized controlled trial. The most recent updated guidelines for the overall management of sepsis were released by the Surviving Sepsis Campaign in 2017.10. It controversially continued to recommend an empiric crystalloid bolus of fluid to all patients. Less controversially, it is recommended to continue close monitoring, a target mean arterial pressure of 65 mmHg, and using lactate as a measure of tissue hypoperfusion and as a guide to resuscitation. The use of central venous pressure to guide fluid resuscitation has been largely discredited, owing to its inability to reliably predict fluid responsiveness. In its place, the guidelines recommend the use of so-called dynamic parameters, including passive leg raise, fluid challenges, pulse pressure variation in response to mechanical ventilation, and other techniques. Many devices and techniques exist to predict fluid responsiveness, but ultimately, clinical judgment must still be used to guide fluid resuscitation and vasopressor therapy in septic shock states. Currently, when crystalloid fluid resuscitation is not effective at raising blood pressure, the vasopressor of choice is norepinephrine, which has been shown to be superior to the other vasopressors. Difficulty in using this as an endpoint for resuscitation. Phenylephrine has been associated with higher in-hospital mortality in septic shock. When norepinephrine requirements increase significantly past the value of approximately 5 mcg/minute, low-dose vasopressin should be added. This is based upon research suggesting a relative vasopressin deficiency in inflammatory vasodilatory shock. The dosing is 0.04 units/minute, a relatively low dose thought to correct this relative deficiency, and may decrease norepinephrine requirements to maintain the blood pressure. High-dose vasopressin is not recommended. When high doses of norepinephrine and added vasopressin are insufficient, epinephrine may then be added, with no data suggesting a clear benefit. The butamine may also be used to augment tissue perfusion if the CO is low. The use of corticosteroids in septic shock has been controversial for over 2 decades. The current recommendation by the Surviving Sepsis Campaign is for low-dose steroids and vasopressor-dependent, volume-replete septic shock. Additional therapies being investigated include a bundle of vitamin C, thiamine, and hydrocortisone, the MERIT protocol, which showed dramatic results in a single center before and after trial. Similarly, foundational concepts such as initial fluid resuscitation versus vasopressor use and even the meaning of lactate as a resuscitation endpoint remain in dispute and are being investigated. The critical care physician is advised to remain abreast of the literature in this rapidly changing arena. Other etiologies of distributive shock. Other etiologies of distributive shock include anaphylactic and endocrine shock. The former occurs in response to an allergic stimulus, with the first-line treatment being epinephrine. Optionally, adjuncts such as Benadryl and steroids may be used. While the former does not manage airway symptoms and may cause hypotension, the latter takes several hours to be effective and has never proven to be of benefit. Endocrine shock results from severe myxedema coma from thyroid deficiency and Addisonian crisis from acquired or iatrogenic hypothalamic pituitary adrenal axis suppression. The diagnosis depends on an accurate history and physical examination in both cases. Often, until laboratory tests rule out coexisting Addison disease, the treatment for myxedema coma includes empiric steroids alongside levothyroxine and lauthyronine. Hypovolemic shock. Hypovolemic shock is characterized by increased SVR and decreased CO, with the latter being secondary to decreased PRO. This is a so-called cold shock, meaning the skin is cold and clammy from the vasoconstriction. For hypovolemic shock from dehydration or fluid losses, such as from prolonged physical activity in warm temperatures or excessive gastrointestinal GI losses and lack of oral intake, the treatment is relatively straightforward to include fluid resuscitation with crystalloid. Hemorrhagic shock. In hemorrhagic shock, blood products are the resuscitated fluid of choice. In these situations, crystalloid administration leads to increased coagulopathy and can increase the blood pressure, resulting in more bleeding, which is exacerbated by the aforementioned coagulopathy. 2 resuscitation strategies are possible: empiric resuscitation with packed red blood cells PRBCS, fresh frozen plasma FFP, and platelets in a ratio designed to roughly approximate, which are tests that purport to accurately measure derangements in coagulation and guide resuscitation strategy. The first strategy, Administration of blood products in an empiric ratio is commonly employed in many centers as part of a massive transfusion protocol to be administered until control of bleeding can be obtained and/or resuscitation endpoints have been met. Alongside this are adjuncts such as the administration of tranexamic acid, which too is highly controversial. It should be noted that a strict 1:1 ratio was shown to be no better than a 1:2 ratio of FFP to platelets to PRBC in patients with severe trauma. Cardiogenic shock. Cardiogenic shock is a cold shock in that it is characterized by decreased CO due to intrinsic failure of the heart as a pump, with compensatory vasoconstriction. Numerous causes for heart failure resulting in cardiogenic shock exist, but the most commonly seen is the acute or long-term sequelae of coronary artery disease. This shock state has multiple variants to include diastolic versus systolic failure and left heart versus right heart failure. Valvular obstruction may also be a cause of dysfunction. Heart failure progresses through 3 stages. Initially, the filling pressure of the ventricle increases, but contractility is preserved at the expense of increased pressure and congestion in the lungs. Next, the stroke volume begins to fall, but an increase in heart rate preserves CO. Finally, CO begins to fall. Right heart failure. The mainstay of right heart failure therapy is straightforward. This includes fluid boluses until the central venous pressure or wedge pressure, if available, is above 15 mmHg, followed by nodulator therapy with dobutamine or milrinone. This being said, fluid therapy must be used judiciously, as dilatation of the right ventricle may cause the septum to bow out into the left ventricle, resulting in decreased left ventricular function, a phenomenon called interventricular interdependence. The nodulators both dilate the vasculature, reducing blood pressure, and promote CO by increasing contractility. They are ideal choices when the CO is low and the SV are high, but often are not options if systemic blood pressure is low. For this reason, nodulators in conjunction with vasopressors such as norepinephrine are a commonly pursued strategy, with the nodulator titrated to the CO and the vasopressor titrated to an appropriate systemic blood pressure. Left heart failure. The two questions in left heart failure are: what is the patient's blood pressure, and is the patient fluid overloaded? While diuretics historically have been given to almost all patients in left heart failure on the theory that such patients are past the inflection point on the Starling curve, in reality, patients who are in cardiogenic shock may be fluid overloaded, underloaded, or eulemic. Alternative measures should be used to determine volume status, including weight, tidal edema, inferior vena cava ultrasound, and other newer non-invasive tools. The other decision point is blood pressure. If the patient is hypertensive, then nitroglycerin, nitroprusside, or nicardipine may be used. All 3 will decrease the afterload, allow for forward flow of blood to peripheral tissues, reduce the myocardial oxygen demand, and protect the heart from ischemic damage. Nitroprusside has the risks of worsening coronary ischemia and of causing cyanide toxicity, and so is less preferred compared to the other agents. If the blood pressure is normal in a state of cardiogenic shock, nodulators may be used. Vasodilators can also be used with caution as long as the blood pressure is maintained. Finally, if both the blood pressure and CO are low, epinephrine, and worsen the patient's condition. This state has an extremely high mortality, and oftentimes, mechanical circulatory support is one of the few options left. These options include intra-aortic balloon pumps, left ventricular assist devices, and extracorporeal membrane oxygenation ECMO. If a facility does not have these resources in-house, the patient should be considered for transfer to a center with these capabilities, possibly by having a mobile unit from the accepting facility arrive at bedside and placing the patient on mechanical circulatory support prior to transfer. Obstructive shock. The etiologies of obstructive shock include tension pneumothorax, cardiac tamponade, constrictive pericarditis, and massive P. In all cases, the treatment is interventional in that they require removal of the cause of the obstructive shock. Options include a needle decompression or thoracostomy tube in the case of pneumothorax, pericardiocentesis or thoracotomy in the case tamponade, and heparinization and systemic or catheter-directed thrombolysis in the case of P. A high index of suspicion is required in making these diagnoses. Myocardial infarction. Both myocardial ischemia and MI are feared entities in the perioperative period, both of them portending significant morbidity and mortality. The lack of ischemic symptoms or electrocardiogram EKG changes associated with a rise in troponins is not a sign of safety, as mortality remains high. 2 fundamental types of MI exist. Type I MI is based upon atherosclerotic plaque rupture and consequent ischemia and infarction of muscle that was being supplied by that blood vessel. In contrast, Type 2 MI is based upon a mismatch of the supply of blood and the heart's demand for it, and is also commonly referred to as demand ischemia. The treatments for each type of MI flow naturally from their causes, revascularization for type I MI and reduction of cardiac oxygen demand for type 2 MI. Type 1 MIS can be broken down into SANE elevation MI STEMI and non-STEMI and STEMI. As its name indicates, a STEMI classically involves symptoms and elevations in cardiac enzymes as well as evidence of SANE elevations on EKG, while an NSTEMI is similar but without EKG evidence of infarction. Unstable angina is a symptom of ischemia, but without cardiac biomarker elevation indicating injury. These critical distinctions drive differences in the immediate management, and it should be noted that unstable angina and NSTEMI are indistinguishable in the first 6 hours, as that is how long it takes troponins to become positive after cardiac injury. All 3 together form part of the spectrum of acute coronary syndrome. The treatment of a type I MI in the postoperative period focuses on a percutaneous coronary intervention with thrombolysis as an option if timely percutaneous coronary intervention is unavailable. In NSTEMI, intervention can be delayed in some cases up to 72 hours. However, the overall intervention decision is complicated by the added burden of deciding on the risks and benefits of full-dose systemic anticoagulation in postoperative patients. In certain populations, such as those who recently underwent neurosurgical procedures, the risks of stroke or death from hemorrhage make percutaneous coronary intervention with its attendant anticoagulation unacceptable, while in other patients, the risks can be accepted. Age as previously discussed. Nitroglycerin, either sublingual or Roman 4, can be given for hypertension and for chest pain. The distinction between a right and left-sided MI is critical, as giving nitroglycerin to reduce the afterload in myocardial oxygen demand in the setting of presumed left-sided MI may reduce the preload, resulting in right-sided heart failure if in fact the patient is suffering a right-sided MI. This could have catastrophic consequences. Pain control with any Roman 4 opiates such as morphine can be used to control chest pain symptoms if not relieved by nitroglycerin. The patient should be given aspirin and additional anticoagulant medications as specified by local protocol and depending upon the course of therapy chosen. Beta blockers should be initiated if there are no signs of cardiogenic shock, as these are cardioprotective. However, if the patient is hypotensive or has a decreased ejection fraction or bradycardia, avoid these. Above all else, have the defibrillator close by, pass preferably on the patient, ready to shock any life-threatening arrhythmias or pace the patient if they go into bradycardia secondary to heart block. Respiratory system. ICUs in many ways were defined by the mechanical ventilator. The first ICU was arguably established by Dr. Bjorn Hodge Ibsen in 1953 in response to a polio outbreak in Denmark. The use of positive pressure ventilation, initially supplied by medical students working in shifts, in combination with intubation, prevented secretions from causing aspiration pneumonitis and pneumonia. saving hundreds of lives. This basic combination of intubation and mechanical ventilation continues to represent a common function of critical care units of all types, and familiarization with both airway management and mechanical ventilation is fundamental to the practice of critical care medicine. Respiratory physiology. Respiratory physiology is characterized by two linked processes: oxygenation and ventilation. Oxygenation refers to the addition of oxygen O2 to the bloodstream from the air, which is typically at a concentration of 21%, also known as the fraction of inspired oxygen phi aqua. Ventilation is the clearance of carbon dioxide CO2 from the bloodstream after the latter has been generated by cellular respiration. It can help to think of these two processes as entirely separate, although in reality, this abstraction breaks down at extremely low-minute ventilations. Both processes rely upon air coming down the oral cavity, into the trachea, through the bronchi and into the lung parenchyma, where blood brought from the pulmonary artery goes through the pulmonary capillaries. This alveolar capillary interface is where gas exchange occurs. If too much blood flow relative to oxygenation capacity is present, it is referred to as shunt physiology. Air exchange in areas that do not have sufficient blood supply is known as dead space physiology. Some amount of both of these is normal. Less than 10% of total CO does not participate in gas exchange, and 20% to 30% of total ventilation does not equilibrate with blood. Increases in shunt fraction occur secondary to asthma, to distension of alveoli from pulmonary edema or pneumonia, to atelectasis, or to P, where excessive CO flows through non-embolized regions. Dead space ventilation takes place when the alveolar capillary interface is destroyed by enfeisement, when the CO is low, or when air overdistends the alveoli during positive pressure ventilation. Oxygen delivery was previously discussed in the cardiovascular system section and is not further discussed here. Fibrotic lungs and interstitial lung disease or acute respiratory distress syndrome are at low compliance. Critically, in the era of mechanical ventilation, low compliance can be a viscous cycle. An initial insult from pneumonia, pulmonary contusion, severe systemic disease like pancreatitis, or other cause can result in a decrease in compliance. Using mechanical ventilation, air is forced into the lungs to deliver a set amount of ventilation. This results in barotrauma, or trauma to the lungs from increased pressure. This barotrauma further decreases compliance. Thus, preventing barotrauma is a key goal of the RSNet protocol, which is discussed later. Oxygen therapy. It is difficult to find a patient in the ICU or floor who does not have a nasal cannula in place, delivering a few liters per minute of oxygen. Nonetheless, it must be emphasized that oxygen itself is a drug, with risks and benefits. 100% phi O2 can be lethal to scuba divers, and supplemental oxygen given to heart attack patients who did not have hypoxia O2 saturation greater than 94% caused increased infarct size at 6 months and no mortality benefit. It should be used only when indicated. In intubated and mechanically ventilated patients, the target phi O2 should be less than 50% if tolerated, as the setting appears to be safe and without risks of pulmonary toxicities, while theoretically the phi O2 should be dropped to 21% if tolerated. This is not commonly done. Non-invasive ventilation. Some patients in impending respiratory failure may avoid intubation with non-invasive ventilatory support via continuous or bilevel positive airway pressure CPAP or BiPAP. Both are often worn at night by many patients with sleep apnea at home and should be provided to such patients in the hospital if indicated. BiPAP in particular has been shown to significantly benefit patients with pulmonary edema from a congestive heart failure exacerbation. They provide the equivalent of positive end expiratory pressure PEEP, helping to keep the alveoli open at the end of expiration. In BiPAP, there are two settings: expiratory positive airway pressure and inspiratory positive airway pressure. The inspiratory positive airway pressure is provided with each inspiratory breath, while expiratory positive airway pressure is the constant support, analogous to what CPAP would provide. These machines are thus well suited to providing support over CPAP in cases of hypercarbic ventilatory insufficiency. It is important to remember the contraindications to such devices to include altered mental status and consequent inability to protect the airway being a near absolute one. Both machines involve a mask worn over the face, and any large volume emesis event can rapidly turn into a large volume aspiration and cardiac arrest event in a tenuous patient. Furthermore, the use of these modalities in patients with fresh esophageal, gastric, or duodenal anastomosis is relatively contraindicated, as the positive pressure can increase upper GI insufflation. Although the normal resting pressure of the lower esophageal sphincter is greater than 10 mmHg, in normal BiPAP settings would be an inspiratory positive airway pressure of 10 mmHg and an expiratory positive airway pressure of 5 mmHg. Many conditions and patient characteristics can reduce this protective mechanism and make the use of BiPAP a riskier proposition. BiPAP can also be used as a bridge from extubation. A recent small randomized trial suggested that extubating a patient directly onto BiPAP reduced reintubation rates, required to protect the airway from aspiration due to neurologic deficits or loss of patency, or to assist with inadequate oxygenation and/or ventilation. The first indication, protection of the airway, is well known by the same GCS less than 8, intubate. While this is treated practically as a commandment in critical care, it should be remembered that significant risks exist during intubations and that there are exceptions to every rule. Impending loss of patency can be caused by airway edema secondary to hereditary angioedema, to airway trauma, to severe allergic reactions, and to airway burns. The latter is often a delayed phenomenon, so assessment of a burned patient for signs of airway injury is essential. The second indication represents a failure of the lungs to accomplish their two tasks without assistance. Rising respiratory acidosis and hypoxia are both reasons to intubate, which can arise from many causes including pneumonia, pulmonary contusion, severe illness, flash pulmonary edema, congestive heart failure exacerbation, and exhaustion from increased work of breathing secondary to metabolic acidosis. High spinal cord injury patients, above C5, may have a delayed presentation of ventilatory failure as their diaphragm weakens, while it was initially compensated for by the use of accessory muscles. Recent work in a multi-institutional study found that 3% of patients who are intubated in the ICU arrest during the procedure, of which 29% could not be resuscitated. Previous work established hypotension and hemodynamic instability as the most predictive factors in peri-intubation arrests, but the causes for these arrests are multifactorial, including hemodynamic shifts induced by induction agents, temporary hypoxia during the procedure itself, and the influence of positive pressure ventilation on venous return to the heart. It is essential to resuscitate patients adequately prior to intubation and to use adjuncts such as vasopressors prior to and during intubation if indicated. Ultimately, while laboratory tests such as arterial blood gas measurements and measurement of tidal volumes using non-invasive ventilators can assist in determining whether or not a patient needs to be intubated, nothing can replace clinical judgment in determining whether a patient requires intubation. Standard modes of mechanical ventilation. Volume assist control. Assist control is one of the most commonly utilized modes of mechanical ventilation, specifically volume assist control. The four basic settings in this mode and most all standard modes include respiratory rate, tidal volume, PEEP, and phi O2. Tidal volume is the amount of air delivered to the lungs, while PEEP represents back pressure that keeps the alveoli open and distended at the end of expiration. Respiratory rate and phi O2 have previously been described. Volume assist control delivers a set tidal volume at a set minimum respiratory rate. If the patient is not breathing spontaneously, their rate is exactly what the patient will receive. If the patient is awake and breathing spontaneously, They will receive that minimum number of breaths unless they are overbreathing the mechanical ventilator, during which time every breath the patient takes, whether spontaneous or ventilator-directed, will be driven to the minimum set tidal volume. These two parameters multiplied, respiratory rate and tidal volume, equal the minute ventilation. It is adjustment in minute ventilation that affects clearance of CO2 from the bloodstream. In contrast, adjustments in O2 and PEEP affect the oxygen saturation. An alternative to this is compliance. With both modes of mechanical ventilation, the free variable airway pressure and volume assist control and tidal volume and pressure assist control must be carefully monitored. Peak airway pressures greater than 35 mmHg are potentially deleterious. The equation for airway pressure is airway pressure equal to airflow airway resistance plus alveolar pressure. Thus, the measured airway pressure itself is not necessarily harmful, but the alveolar pressure is and can lead to barotrauma. When faced with elevated peak airway pressures, the first step is to rule out causes of increased airway resistance such as a King 2, auto-peep from breath stacking, and other causes such as tension pneumothorax or asthma. Ways to diagnose this include measuring the pressure during an inspiratory breath pause, also known as the plateau pressure. This is a direct reflection of the alveolar pressure. A high plateau pressure in conjunction with a high peak airway pressure indicates that the problem is poor pulmonary compliance, but a low plateau pressure indicates the problem is more proximal. Synchronized intermittent mandatory ventilation. Synchronized intermittent mandatory ventilation SIV is another commonly used mode. The primary difference between assist control and SIV involves the spontaneous breaths. In assist control, every patient-initiated breath receives full support up to the set tidal volume. In SIV, a fifth parameter is set pressure support. This value is analogous to the inspiratory positive airway pressure setting on BiPAP and provides a set level of pressure support for all spontaneous breaths. Thus, in SIV, all spontaneous breaths generate whatever the patient is capable of doing with the applied pressure support. Whether assist control or SIV forms, the default mode of mechanical ventilation in an ICU is typically practitioner and unit specific. Pressure support ventilation. Another fundamental mode of mechanical ventilation is pressure support ventilation. It is directly analogous to a BiPAP machine. Every breath the patient takes is supported by a set pressure support with additional PEEP that is constant throughout the respiratory cycle. This mode is an excellent tool to wean the patient from mechanical ventilation and is discussed further under extubation. Advanced modes of mechanical ventilation. High-frequency oscillatory ventilation. High-frequency oscillatory ventilation is an infrequently utilized mode involving extremely low tidal volumes at a high rate. It is often used as a salvage mode and or a bridge to ECMO in severe Rs. Two high-quality randomized controlled trials showed no mortality benefit and possible increased mortality from use of this mode. However, in the neonatal population, which is beyond the scope of this chapter, there are data documenting benefit. Airway pressure release ventilation and biphasic positive airway pressure ventilation. Both airway pressure release ventilation and BiPAP ventilation provide two levels of CPAP that allow a mixture of spontaneous and ventilator-mandated breaths. They minimize the pressures. Specifically, airway pressure release ventilation consists of a high CPAP pH for a greater period of time TH, which then falls to a lower pressure PL for a shorter period of time TL. Our level is similar, but with a prolonged TL. The specifics of these mode settings are beyond the scope of this text. But in brief, the pH is set at a level to ensure oxygenation, while PL and TL are set to ensure adequate ventilation. While the data on these modes support improved oxygenation, they have not been shown decreased mortality. Opponents of these modes maintain that they can achieve similar results by adjusting the inspiratory and expiratory times in assist control with resulting inverse ratio ventilation, pressure-regulated volume control, and adaptive support ventilation. These are patented modes of mechanical ventilation and are only available with certain manufacturers. Pressure-regulated volume control adjusts the driving pressure from breath to breathe to achieve a set tidal volume, with set limits on maximum inspiratory pressure. In doing so, one is able to reap the benefits of a pressure mode, primarily a decreased risk of barotrauma with the ease of use of a set volume control mode. There has been no mortality benefit documented with this mode, although it does decrease the plateau pressure. Adaptive support ventilation seeks to minimize the patient's work of breathing and achieving a target minute ventilation. It too has no mortality benefit. However, secondary outcomes such as ventilator days will reduce. Extracorporeal membrane oxygenation. ECMO is an option in those patients with refractory hypoxemia to all other interventions. It is not without risks, as the anticoagulation required can cause devastating bleeds and cerebrovascular accidents, and limb ischemia may also occur. In considering ECMO, ethical issues may arise. In the setting of irreversible pulmonary pathology, ECMO may not be an option. It is too high risk and resource intensive as a destination therapy, unless the patient qualifies as a lung transplant candidate. Cannulation for ECMO may be performed bedside and can be venovenous or venoarterial, with the latter mode providing circulatory support as well as oxygenation and ventilation. Extubation or tracheostomy. Unless significant hemodynamic instability or other considerations prevent, one should always be weaning the patient from the mechanical ventilator. So much so that even an open abdomen is not contraindication to liberation from the mechanical ventilator. There are a plethora of weaning techniques, and none have truly been documented superior. The decision to extubate a patient is based on the following broad concepts. 1. Is the patient's airway patent and can they protect it? 2. Can the patient support themselves with sufficient oxygenation and ventilation? Various parameters are in play for each decision. In assessing airway patency, a leak test is performed. Following deflation the endotracheal tube cuff, a loss of 10% to 20% of the ventilated volume should be observed. If this is not the case, one may still proceed with extubation. However, it is advisable to extubate over a bowgie and to have equipment bedside for possible reintubation. Alternately, Roman 4 steroids and reassessment in 24 hours are a more conservative approach. The patient must also be able to protect their airway, which is evaluated by the patient's GCS and /O1s. Neurosurgical patients, however, such decisions should be made by experienced clinicians. There are numerous means of assessing the oxygenation and ventilation capabilities of the intubated patient. The successful tolerance of the spontaneous breathing trial is the best predictor of successful extubation. A spontaneous breathing trial is performed by placing the patient on pressure support ventilation 5/5 at 40% O2. These settings essentially provide compensation for the endotracheal tube. Tolerance for 30 minutes equates with passing the spontaneous breathing trial. The rapid shallow breathing index is another commonly employed measure. While the patient is on pressure support, it is calculated by dividing the respiratory rate by the tidal volume L. While a rapid shallow breathing index less than 105 is predictive yet not a guarantee of a successful extubation, a value greater than 105 is essentially a guarantee of extubation failure. Other respiratory mechanics to include respiratory rate less than 25, negative inspiratory force more negative than 20, tidal volume greater than 5 ccs/kilogram, minute ventilation less than L/minute, and vital capacity greater than ccs/kilogram are all indicative of successful extubation. If a patient is likely to remain intubated for an extended period of time, conversion to a tracheostomy should be considered. While the data on when to perform a tracheostomy are debatable, a commonly used date for evaluation is on mechanical ventilator day 7. Advocates for early tracheostomy cite decreased sedation needs, decreased airway risks, and more expedient liberation from the mechanical ventilator as benefits. Pulmonary pathology. Pulmonary embolism. While labeled pulmonary, This is a disorder of the clotting system more than a primary insult to the lung parenchyma, and its primary pathophysiology is to increase PVR and, ultimately, right heart failure. Nonetheless, it is important to recognize that P's can cause significant dead space physiology with resultant hypoxia. Prevention is the best weapon to include early ambulation, intermittent pneumatic compression devices, and prophylactic anticoagulation in at-risk populations. The treatment is systemic anticoagulation, heparin drip, or weight-based low molecular weight heparin to prevent clot propagation, and acute thrombolytics or catheter-directed therapies or surgery in rare cases. ECMO may also serve as a bridging therapy in extreme cases. Pneumonia. Pneumonia is diagnosed by a new infiltrate on chest radiograph together with fever, leukocytosis, and / or purulent secretions. That being said, almost every patient in an ICU will have alternate reasons for some or all of those findings, and thus the diagnosis can be difficult. Community-acquired pneumonia. For patients presenting to the emergency center with community-acquired pneumonia, the Infectious Diseases Society of America and the American Thoracic Society offer extensive guidelines. For those patients presenting with 3 of the following factors: tachypnea, power ratio less than 150, multilobar infiltrates, confusion, uremia, leukopenia, thrombocytopenia, hypothermia, or hypotension requiring fluid boluses, the recommendation is for direct ICU admission. In those patients originally admitted to the ward and then who required transfer to the ICU, there was noted to be increased mortality. The mainstay of the treatment of community-acquired pneumonia is either a respiratory fluoroquinolone or a beta-lactam together with a macrolide. Recent evidence about the risk of aortic aneurysm and dissection with the use of fluoroquinolones and the increased mortality with macrolides suggests caution with the use of either regimen. A mortality benefit has been noted with macrolides. Healthcare-associated pneumonia and ventilator-associated pneumonia. The diagnosis of healthcare-associated pneumonia as HAPS and ventilator-associated pneumonia as VAPS are loosely defined as pneumonia diagnosed within 48 hours of hospital admission and within 48 hours of intubation, respectively. That being said, the diagnoses of these two entities are controversial, not least because they are tracked as hospital quality measures. This has inevitably led to significant efforts by hospitals to adopt practices to reduce and in some instances artificially reduce the rates of these two entities. Prior to initiating therapy in both HAP and VAP, it is critical to send cultures bronchoalveolar lavage or by endotracheal aspirate. If the patient has risk factors for multi-drug resistant pathogens, defined as prior antibiotics within 90 days, HAP should be treated with a regimen of vancomycin, cefepime, and levaquin. Patients with VAP are at high risk for multi-drug resistant organisms, and any with septic shock, ORS, 5 or more hospitalization days, and / or renal replacement therapy should be covered with the same antibiotics, until cultures allow targeting of therapy, for a total of 8 days. Patients without these risk factors should be treated with cefepime alone. However, it should be noted that local practices, formularies, and antibiotic resistance patterns vary widely throughout the United States and the world. Development of guidelines in conjunction with an ICU pharmacist will lead to improved quality of care and outcomes. The key in managing HAPs and VAPs is prevention. All patients should have the head of their bed elevated to 30 degrees, a measure that can prevent HAPs, along with incentive spirometry and early mobilization. Additionally, patients on a mechanical ventilator should have daily chlorhexidine rinses and interruptions of sedation. But the ultimate prevention measure for VAP is liberation from the mechanical ventilator as early as safely possible. Acute respiratory distress syndrome. ARDS is a response of the lung to multiple inciting factors to include blood product transfusions, sepsis, pneumonia, or severe pancreatitis, pulmonary contusion from trauma, and bleeding and / or hypotension. It is characterized by decreasing ability to oxygenate and decreased compliance of the lung. The formal definition known as the Berlin definition was adopted by a joint effort of several societies. It requires bilateral infiltrates on chest radiograph or CT scan. A PaO2/5 aqua ratio less than 300 is mild, less than 100 is moderate, and less than 100 is severe. An inciting factor within 7 days prior to the diagnosis, and a rule out of hydrostatic edema as a cause of the bilateral infiltrates. It should be noted that patients can have hydrostatic edema from heart failure and ARDS simultaneously. The management of ARDS revolves around mechanical ventilator settings, as previously discussed in this chapter. In a landmark trial ARDS-NET, the mainstay of treatment was labeled lung protective ventilation. It consists of several goals. Plateau pressure 30 centimeters H2O requires high PEEP settings. pH 7.30 to 7.45. These are often met via a comprehensive guideline / algorithm figure 22.1. As shown here, there are many adjuncts to assist in a sensible first step. Additionally, deep sedation and / or neuromuscular blockade with paralytics can then be employed to ensure lack of any ventilator asynchrony, although some authorities maintain this step is unnecessary if sedation is sufficiently deep. Finally, prone positioning is one of the few options that have been shown. Fig. 22.1 Ben Taub Hospital Refractory Hypoxemia Guidelines September. ECMO. Experienced personnel in this technique. Placing a patient prone significantly reduces access, and turning a patient who has many lines and other attachments is not a risk-free endeavor. Close coordination with nursing staff and all ancillary staff is required. If utilized, it should be used early in the course of ARDS. ECMO serves as a final option for refractory ARDS. The Cesar trial documented reduced mortality for patients with ARDS referred to ECMO centers. That being said, approximately 25% of the group of patients transferred for possible ECMO did not actually receive ECMO. The more recent ALIA trial concluded that there was no significant benefit for ECMO and was terminated early for futility. However, at the time of termination, there was an absolute 10% mortality benefit in the ECMO arm. Ultimately, it seems the availability of ECMO may be a correlate for an institution that is skilled in treating ARDS and sees a high volume of such patients. As such, adoption of standard guidelines and algorithms is likely to improve quality of care and mortality. Steroids, inhaled nitric oxide, inhaled epoprostenol, and high-frequency oscillatory ventilation techniques have all been shown to have no mortality benefit and are not commonly used, although they do improve hypoxia. Similarly, the alternative modes of mechanical ventilation previously discussed, as well as inverse ratio ventilation, do not have a proven mortality benefit. Gastrointestinal system, nutritional requirements of the critically Roman III patient. The energy requirements of the critically ill patient are higher than the baseline caloric demands of the average patient due to the hypermetabolic state that is induced by acute stressors. Major trauma, surgery, burns, or critical illness such as sepsis, congestive heart failure, or respiratory failure induce a catabolic state with an increase in inflammation, cytokines, and subsequent loss of weight and lean body mass. Combined with underlying comorbidities, bed rest and inactivity, and poor oral feeding, it becomes easy for the overall metabolic demands of a patient to exceed nutritional intake and result in malnutrition, poor healing, and an increase in complications. The metabolic demands of critical illness require the mobilization of macronutrients to adequately supply the immediate high energy demands of acute illness. The stress response is characterized by an increase in tissue catabolism, high oxygen consumption, and a net negative nitrogen balance due to proteolysis and amino acid oxidation. Catabolic hormones including glucagon, cortisol, and catecholamines induce glycogenolysis, gluconeogenesis, and mobilization of free fatty acids and cause skeletal muscle breakdown. The resultant stress, hyperglycemia, and accompanying insulin resistance ensure that an adequate supply of energy is immediately available in an attempt to satisfy the increased metabolic strain. The nutritional needs of the patient will vary as they shift from an acute catabolic phase to an anabolic recovery phase. There are several contradictory studies demonstrating that underfeeding or overfeeding both have their advantages and disadvantages when it comes to managing critically ill patients. However, it should be stressed that each patient's nutritional requirements are unique, and the etiology of illness, comorbidities, and barriers to nutrition should always be taken into consideration. The components of the patient's overall energy expenditure include the resting energy expenditure 60% minus 70%, physical activity and exercise 20% minus 30%. Sure, it is based on the fact that nutrients, carbohydrates, fats, and proteins are converted into CO2, water H2O, and heat in the presence of O2 to produce adenosine triphosphate. Thus, a patient's overall energy expenditure can be calculated by measuring the amount of O, consumed O2, and CO, produced VCO2 by the body. These values can then be applied to the modified Weir calculation in order to calculate a patient's overall energy expenditure. Energy expenditure kcal/day equal to plus x 1440. Despite its accuracy and usefulness, there are several limitations that preclude the universal application of indirect calorimetry for all critically ill patients. The high cost of the machines and necessary training make widespread use fiscally impossible. Prerequisites to testing include the patient being in a quiet and relaxed environment, fasting for at least 5 hours, without exercise for at least hours, and having had no stimulatory medications or supplements such as nicotine or caffeine. Additional variables that can affect the accuracy of indirect calorimetry measurements include supplemental oxygen administration, significant ventilatory support, presence of air leaks or chest tubes, recent anesthetic use, and continuous renal replacement therapy. There are several predictive equations available that can be used to measure a patient's overall energy expenditure. However, their accuracy is poor when compared to indirect calorimetry. Many of them include variables that are constantly changing and affect the patient's overall energy expenditure, such as weight, medications, and body temperature. According to guidelines published in 2016 by Society of Critical Care Medicine and the American Society of Parenteral and Enteral Nutrition, optimal nutrition requirements for the critically ill patient are roughly 25 to 30 kilocalories/kilograms/day. Of this, protein is the most important macronutrient, and weight-based equations can be used to estimate daily protein requirements 1.2 to 2 g/kilograms/day. Compared to carbohydrates and fats, protein requirements are proportionally higher and vital for wound healing, maintaining, and preventing loss of lean body mass, and supporting immune function. Initial identification of patients at risk for malnutrition is pivotal for early intervention and avoidance of potential complications. Upon admission to the ICU, every patient should have a nutritional assessment, calculation of their energy and protein requirements, and a tentative plan for initiation of enteral or parenteral feeding. Traditional serum protein markers can be obtained to establish a general idea of a patient's nutritional status, but each has its limitations. Serum albumin, transferrin, and prealbumin are all created in the liver, and their levels can be reflective of a patient's overall protein status. Serum albumin has a longer half-life of approximately 18 to 20 days, which can help to establish what a patient's most recent nutritional status has been prior to hospitalization. However, hepatic disease and renal disease can decrease serum albumin levels, and neither acute starvation nor nutritional supplementation will result in a measurable change in the acute ICU setting. Serum transferrin has a half-life of approximately 8 to 9 days, but levels can be altered based on a patient's serum iron levels and systemic inflammation. Transferrin should only be considered as a marker of protein status when serum iron levels are normal. Lastly, prealbumin has a half-life of 2 to 3 days, and levels rapidly fluctuate as a representation of catabolism, inflammation, or transition to an anabolic state. Unfortunately, these serum markers are negative acute phase reactants, and in a setting of significant stress, value should be interpreted in conjunction with the patient's hospital course and clinical status. C-reactive protein may serve as an overall marker of inflammation and stress with which to take into account. Tissue imaging techniques are now recognized as accurate and validated means of analyzing a patient's body composition and estimating lean body mass. CT imaging allows for cross-sectional measurements and quantification of skeletal muscle that can be easily compared to prior or subsequent studies. Cross-sectional imaging at the third lumbar vertebra provides precise estimates of total body composition of adipose tissue, total body muscle volume, and lean muscle volume. Investigations into alterations of sole's muscle quality and density correlate with changes in a patient's nutritional status and length of hospital stay. Despite these benefits, CT imaging is quite limited by cost and potentially unnecessary exposure to ionizing radiation. Bedside use of ultrasound has developed as an easily reproducible and harmless means to measure a patient's muscle mass that can be repeated for comparison. Although ultrasound lacks the negative effects of CT scan, its use has not yet been validated for patients in the ICU. Without a single modality to reliably and accurately measure a patient's overall nutritional status, one must continue to assess the patient with a complete physical exam, use clinical judgment, and gather additional data from ancillary studies to develop an individualized and comprehensive plan for nutritional support, enteral and parenteral nutrition, along with timing and proportion of nutrients. While administration of nutrition is an important decision that is based on the patient's clinical status and risk for complications, enteral nutrition refers to the administration of feeds and fluids via the intestinal route, be it orally or via a feeding tube, and should be the first choice for nutrition administration when possible. In addition to being the physiologic manner in which we nourish ourselves on a daily basis, there are several additional benefits. Enteral nutrition aids in preserving gut integrity by maintaining tight junctions between intraepithelial cells, induces blood flow to the intestine, promotes intestinal microbial diversity and intestine-mediated immunity, and stimulates the release of endogenous hormones and digestive enzymes. Patients who are intubated, altered, sedated, at risk for aspiration, or require additional caloric support can be initiated on enteral nutrition via a nasogastric tube or Dopphoff tube. One place, these tubes should have their positions confirmed radiographically before they are used. Nasogastric tubes have the advantage of being able to be used for feeds, medications, and gastric decompression and are less likely to clog. Dopphoff tubes are softer, more flexible, can be positioned post, ligament of traits, and are better tolerated when needed for longer periods of time but are unable to be used for decompression and have a tendency to clog due to their smaller diameter. Post, ligament of traits feeding has been shown to decrease infectious morbidity and ICU length of stay compared to intragastric feeding. Post, ligament of traits positioning is most beneficial for patients who are at high risk of aspiration, have delayed gastric emptying, or have proven intolerant to gastric feeding. Proper tube positioning can be difficult and if timely placement is not possible, and it is best to avoid delay and initiate early gastric feeding while awaiting small bowel positioning. Interrupted for patient care, bedside procedures, diagnostic imaging, and prior to operative intervention, among other things. Absolute contraindications to the administration of enteral nutrition include ileus, bowel discontinuity, bowel obstruction, active intestinal hemorrhage, and hemodynamic instability. If a patient is hypotensive or has no onset and or increasing vasopressor requirements, enteral feed should be held until the patient is stabilized. Administration of enteral feeds in the setting of hypotension has the potential to worsen bowel ischemia, leading to necrosis and bacterial overgrowth. Conversely, patients who have minimal and stable vasopressor requirements do better with early enteral nutrition administration. While there are no set guidelines regarding enteral nutrition in the setting of vasopressor support, it is important to recognize any potential signs of bowel ischemia, including feeding intolerance, abdominal distension, no onset ileus, and worsening metabolic acidosis. Parenteral nutrition provides nutrients and fluids through enrollment 4 and is typically reserved for patients with contraindications to enteral nutrition. It is a much more reliable means of providing calories as there are less interruptions to administration and the caloric needs of the patient are met more rapidly. Parenteral nutrition is also customizable to meet each patient's individual needs by altering the total amount of fluids, dextrose, amino acids, lipids, electrolytes, vitamins, and trace elements. When a patient is receiving parenteral nutrition, they should have a daily set of chemistries, the triglyceride level prior to initiation of lipid emulsion, and a weekly set of liver enzymes. Parenteral nutrition can be given in 2 forms: as total parenteral nutrition via central venous access or as partial parenteral nutrition via peripheral Roman 4 access when a patient is able to tolerate minimal oral feedings but needs supplementation or is awaiting central venous access. Although Roman 4 nutrition seems ideal, studies have shown that early parenteral nutrition within 48 hours of critical illness does not convey any mortality benefit and may be associated with increased infectious morbidity. In well-nourished patients, it is typical to wait up to 7 days before starting parenteral nutrition in the hopes that the patient will be able to feed enterally. Complications associated with parenteral nutrition include central line, associated bloodstream infection, collapse, vascular thrombosis, hypertriglyceridemia, hyperglycemia, hepatic steatosis, and cholestasis. Patients receiving parenteral nutrition are at higher risk for collapse compared to patients with a central line not receiving nutrition. The most common organism is Staphylococcus, and parenteral nutrition is the strongest risk factor for nosocomial candidemia. Metabolic complications include refeeding syndrome and overfeeding. Refeeding syndrome occurs secondary to full caloric administration after a period of starvation resulting in hypokalemia, hypophosphatemia, and hypomagnesemia and can be avoided by slowly introducing calories and increasing the full caloric requirements over time. Overfeeding results in electrolyte imbalances, hyperglycemia, and hypertriglyceridemia and complicates weaning from mechanical ventilation. Disuse of the GI tract results in intestinal mucosal atrophy and loss of microvilli, bile stasis, cholelithiasis, and hepatic steatosis. Long-term parenteral nutrition places patients at risk for developing acute cholecystitis, cirrhosis, and liver failure and is a major cause of mortality related to patients with short bowel syndrome. Comparisons between enteral and parenteral nutrition administration have found no impact on mortality in critically ill patients. However, patients receiving enteral nutrition have less nutrition, have lower rates of pneumonia and collapse, and trauma patients have lower rates of abdominal abscess formation. There are also cost differences as outlined by the calories trial, indicating that overall patient care costs were higher with parenteral administration. Overall, when faced with the choice of initiating enteral or parenteral nutrition in the absence of absolute contraindications, there are clear benefits for the patient and overall cost savings with the use of enteral nutrition. Stress ulcer prophylaxis. The GI mucosa is highly sensitive to the hemodynamic alterations often experienced by the critically ill patient. Splanchnic hypoperfusion, mucosal ischemia, reperfusion injury, and decreased mucosal protection all can result in the formation of ulcerations that have the potential to bleed or cause viscous perforation. Mechanical ventilation influences a patient's hemodynamics, especially in cases that utilize high PEEP and or higher than normal tidal volumes. Increased intrathoracic pressures decrease venous return and right heart filling, thus decreasing CO. Gastric ulcerations can be found in up to 90% of patients after severe trauma or hypotension, but their consequence is not clear as only a small percentage of these patients go on to have clinically relevant GI bleeding. Classically, patients requiring mechanical ventilation for greater than 48 hours and the development of coagulopathy have been identified as the 2 main risk factors associated with the formation of GI ulcerations and GI bleeding. These patients are often administered gastric acid suppressants such as proton pump inhibitors (PPIs), histamine 2 receptor antagonists, or gastric mucosa protective agents either as prophylaxis or treatment. A recent Inception cohort study looking at 1,034 patients with overt GI bleeding in the ICU secondary to gastric ulceration identified the following risk factors: 3 or more comorbidities, liver disease, renal replacement therapy, acute coagulopathy, and a high sulfur score on ICU day 1.25. Additional clinical considerations for which prophylaxis may be given include patients with elevated intracranial pressures, Cushing ulcer, Burns curling ulcer, septic shock, cardiogenic shock, high-dose corticosteroid use, chronic or high-dose nonsteroidal anti-inflammatory drug use, kidney or liver failure, and prior history of gastric ulceration or GI bleed. With such a broad range of risk factors, it is reported that greater than 80% of critically ill patients are routinely administered either a PPI or histamine 2 receptor antagonist as stress ulcer prophylaxis. Gastric acid suppression with histamine 2 receptor antagonists has been shown superior to gastric mucosal protection with succulfate in preventing GI bleeding, making PPIs and histamine 2 receptor antagonists the main choice for prophylaxis and treatment. When comparing PPIs to histamine 2 receptor antagonists, PPI administration is associated with decreased GI bleeding rates, but no difference in mortality. However, gastric acid suppression has been shown to result in increased morbidity secondary to nosocomial pneumonia, infection with Clostridioides previously Clostridium difficile, and less commonly, thrombocytopenia, MI, and drug interactions. Gastric acid is a natural barrier against pathogens, and suppression can lead to gastric and duodenal bacterial overgrowth and increased survival rates of C. difficile. For these reasons, histamine 2 receptor antagonists are preferred for stress ulcer prophylaxis. Despite prior evidence demonstrating the efficacy of GI prophylaxis in decreasing the incidence of significant GI bleeding, these data are now in question. There is controversy regarding the citation and the practice of early enteral feeding for GI mucosal maintenance and protection. For now, until better data from a high-quality randomized placebo-controlled trial can be conducted, stress ulcer prophylaxis remains the standard of care. Hepatic system, perioperative management of the cirrhotic patient. Cirrhosis in a critically ill patient is a difficult and complex medical condition to manage because of its effects on almost all other organ systems. The prevalence of cirrhosis has and will continue to increase as the obesity epidemic in the United States worsens. Many patients with subclinical cirrhosis are unaware of their disease, and any patient who is admitted to the ICU with risk factors for the development of cirrhosis should be adequately screened. Risk factors for liver disease include chronic alcohol or substance use, sexual promiscuity, blood transfusions, tattoos, a history of jaundice, and family history of liver disease. A thorough review of a patient's medications and specific questions regarding the use of herbal medications are important, as some herbal medications can be hepatotoxic. Clinical features that should raise suspicion for underlying liver disease include fatigue, pruritus, jaundice, obesity, temporal wasting, hypererythema, spider telangiectasias, gynecomastia, sites, splenomegaly, apomegacy, and testicular atrophy. Laboratory evaluation for suspected cirrhosis includes a complete blood count looking for anemia and thrombocytopenia, a basic metabolic panel to evaluate renal function, a coagulation panel to assess the liver's intrinsic ability to generate clotting factors, and a hepatic function panel. Radiologic examination should start with a right upper quadrant ultrasound with duplex, as it is safe for the patient, relatively inexpensive, can be done at the bedside, is easily repeatable, and is highly sensitive for vascular abnormalities such as thrombus. Evaluation with elastography also allows for quantitative measurement of liver stiffness that occurs with cirrhosis. Ultrasound is, however, limited by the patient's body habitus and the variability and quality of images obtained that can occur, as it is technician dependent. Alternatively, contrast-enhanced cross-sectional imaging using CT or MRI allows for very detailed visualization of the entire liver, spleen, and portal system, is reliably reproducible with little variation, and is not limited by patient habitus other than the patient being able to physically fit in the scanner. In comparison to ultrasound testing, cross-sectional imaging is more expensive, often requires transportation that can be dangerous in unstable patients, and can result in nephrotoxicity with iodine or gadolinium contrast administration. CT imaging requires exposure to ionizing radiation, and MRI cannot be obtained if the patient has a metal device or implant. The systemic alterations caused by cirrhosis lead to a number of complications that occur when the body is no longer able to compensate for the disease state. The clinical manifestations of decompensated cirrhosis include ascites, esophageal variceal bleeding, hemorrhoid formation and bleeding, bacterial peritonitis, hepatic encephalopathy, hepatopulmonary syndrome, and hepatorenal syndrome. The mortality rate at 1 year with decompensated cirrhosis is 20%, which increases to 57% when esophageal bleeding occurs, and the overall median survival is less than 2 years. Patients with decompensated cirrhosis have limited physiologic compensatory reserve to be able to tolerate a significant insult such as trauma or emergency general surgery, severe imbalances, and sepsis. Preoperative risk stratificate ion is an important piece of data that can help guide therapy for cirrhotic patients when surgical intervention is non-urgent. Considerations must include not only the severity of liver disease but also the urgency of intervention in addition to comorbid conditions. The stage of cirrhosis can be estimated using the Child-Pugh-Turcotte score to categorize a patient as compensated class A, mildly decompensated class B, or severely decompensated class C. Table 22.1. The Child-Pugh-Turcotte score was originally developed to predict operative mortality in patients presenting with cirrhosis and esophageal bleeding and is now used to estimate a patient's overall prognosis. It is calculated utilizing a patient's prothrombin time PT, standardized and calculated as an international normalized ratio, serum total bilirubin, serum albumin, and grading of ascites and hepatic encephalopathy. Child-Pugh-Turcotte class A corresponds with a 10% perioperative mortality for abdominal surgery, 30% for class B, and 80% for class C. While the Child-Pugh-Turcotte score was created as a means of surgical risk stratification, it does not take into consideration renal function and is limited by subjective assessment of ascites and hepatic encephalopathy. An alternative risk stratification of predicting the 3-month mortality rate after a transjugular intrahepatic portosystemic shunt procedure used to treat cirrhosis-induced portal hypertension and has since been found useful for assessing long-term prognosis with cirrhosis and prioritizing candidates for liver transplantation. A patient's MEL score is reproducibly calculated using objective data, serum sodium, serum creatinine, serum total bilirubin, and INR level. There are many caveats that alter a patient's MEL score, such as the presence of hepatocellular carcinoma or hepatopulmonary syndrome, but those are more applicable for liver allicate ion and will not be discussed here. Calculated MEL scores less than or equal to 11 have a 3-month mortality between 5% and 10%, scores between 12 and 25, between 25% and 54% mortality, and scores greater than or equal to 26, 55% to 80% mortality. Because neither of these calculators were developed with the intention to be used as predictors for general operative mortality for cirrhotic patients, the Mayo Clinic has since developed a risk stratification tool assessing postoperative mortality for abdominal, orthopedic, and cardiac surgery in cirrhotic patients. Regardless of which assessment tool is utilized, it should not be used to decide clinical decisions, but should be treated as additional data to help guide the clinician to better manage such a complex disease. Table 22.1 Child-Pugh-Turcotte classificate ion for severity of cirrhosis. Points: clinical and LAB criteria 1, 2, 3 encephalopathy none, grade 1 or 2, grade 3 or 4 ascites not mild to moderate diuretic responsive, severe diuretic refractory bilirubin Mg/DL less than or 2, 3 greater than 3 albumin G/DL greater than 3.5, 2.8, 3.5, less than 1.8 prothrombin time less than for 4, 6 greater than 6 seconds per lung less than 0.7, 1.7, 2.3 greater than 1.3 international normalized ratio class of BC description mild, well compensated disease moderate, significant functional compromise severe, decompensated disease points 5, 6, 7, 9, 10, 15. Table 22.2 model for end-stage liver disease MEL scoring system. MEL equal to 3.78 times log serum bilirubin Mg/DL plus 11.2 times log INR. Errative optimization can be difficult, especially in advanced stages of disease. Coagulopathy is a major concern in the pre- and postoperative period, as these patients often have decreased production of coagulation factors, thrombocytopenia, and dysfunctional platelets secondary to malnutrition, sequestration, myelosuppression, and renal failure. Platelet count goals prior to surgery are institutional and surgeon dependent, but counts less than 50,000/μl for moderate risk and less than 100,000/μl for high risk procedures should be corrected. Correction of coagulopathy with vitamin K and cryoprecipitate is preferred over FFP in order to minimize fluid overload and should be guided by TG, which assesses not only coagulation but also platelet function, quad strength, and fibrinolysis. Patients with cirrhosis are often malnourished, which is associated with increased perioperative complications as previously discussed. Nutritional optimization is important to support the immune system and promote wound healing and recovery. Complications of ascites, fluid overload, and electrolyte abnormalities can lead to respiratory failure and hemodynamic collapse. Portal hypertension results in splanchnic vasodilation, reduces flow, and causes compensatory retention of water and sodium to increase the circulatory volume, resulting in hyponatremia and fluid overload. Management of liver injuries. The liver is the most commonly injured abdominal organ in blunt trauma and the second most common in penetrating injuries. Liver injuries are graded according to the American Association for the Surgery of Trauma (ASFRI) VI based on hematoma, laceration, size, and vascular involvement. The decision for operative or non-operative management of liver injuries should be based not solely on OS guidelines, but more so on the hemodynamic status of the patient and associated injuries. Although high-grade injuries more often require operative intervention, it is the anatomic injury and its physiologic effects that should dictate management. Patients with blunt liver injuries and either hemodynamic instability or peritonitis should be taken to the operating room emergently for exploratory laparotomy. If the patient is hemodynamically stable and without peritonitis and does not have associated injuries requiring emergent operative intervention, then a CT scan with Roman 4 contrast should be obtained to properly grade the injury and assess for active extravasation of contrast blush. Any arterial extravasation or pseudoaneurysm on CT scan should be further assessed/managed with angiography for selective embolization. Proximal hepatic, right hepatic, or left hepatic artery embolization should be avoided. Injury grade alone is not an indication for embolization in the absence of active extravasation. Patients with blunt liver injuries should be admitted to a monitor setting for continuous vital sign monitoring, assessment of urine output, and frequent laboratory draws. Management of penetrating abdominal injuries has been an evolving practice as more institutions become comfortable with non-operative and expected management. As with blunt injuries, any patient with hemodynamic instability or peritonitis should be taken for emergent exploration. Patients undergoing CT imaging with findings of hollow organ injury should undergo laparotomy, and those with thoracoabdominal injuries concerning for diaphragm involvement should undergo either laparotomy or laparoscopy for further evaluation and repair. Non-operative management can be successful, proving that selective cases of complications of non-operative management of liver injuries include delayed hemorrhage, bile and biloma, hemophilia, necrosis, and abscess formation. Delayed hemorrhage with hemodynamic instability should be managed with surgical intervention but otherwise evaluated by triple-phase CT imaging with subsequent angiography and embolization if stable. Hemophilia, often presenting as upper GI bleeding, should be initially managed with angiography and embolization but may require surgical intervention if uncontrolled. Bile and biloma formation may be managed by percutaneous drainage with endoscopic retrograde Challen-Gap and creatography with stenting strongly encouraged. Preferred management of delayed bile peritonitis or rupture of subcapsular hematoma is with laparoscopy with early endoscopic retrograde Challen-Gap and creatography for suspected bile leak. For most hepatic abscesses, image-guided percutaneous drainage is the preferred management with surgical intervention on a case-by-case basis as initial therapy or following failure of percutaneous drainage. Patients who develop hepatic necrosis may be managed by observation only, although in cases where surgical management is required, formal resection of involved segments is preferred to serial debridement. Renal system physiology. Renal dysfunction results in significant morbidity and mortality in a critically ill patient, and some element is seen in up to 15% of ICU patients. Not only does it affect the key functions of the kidney, electrolyte, acid-base, and volume homeostasis, it also affects drug disposition and other critically stressed organ systems. Anatomically, the kidneys are supplied by the right and left renal arteries and drained by the right and left renal veins. At the glomerular level, blood is supplied by the afferent arteriole, traverses the glomeruli, and exits via the efferent arteriole. Relative vasoconstriction of the afferent and efferent arterioles dictates the filtration levels of the kidney. Additional concentration and dilution of urine in the collecting system occur in response to stimuli such as antidiuretic hormone ADH, atrial natriuretic peptide, and aldosterone. Overall, the kidneys respond to different states to maintain homeostasis in volume, acid-base, and electrolyte status. Acid-base disturbances. Acid-base disorders are common in the ICU and require a thoughtful approach to determining their etiology such that appropriate therapy can be instituted to avoid potentially fatal complications. Be mindful that primary derangement in one area often results in a compensatory derangement in the other, i.e., metabolic acidosis will result in a compensatory respiratory alkalosis. Metabolic acidosis. There are many causes of a metabolic acidosis, with all being categorized as either a high or normal anion gap acidosis. High anion gap acidosis occurs when there is excessive ingestion, production, or retention of a strong acid. Etiologies include lactate, ketones, sulfates, or metabolites of ethylene glycol, methanol, or salicylate among others. Normal or non-anion gap acidosis exists when chloride is reabsorbed in place of bicarbonate resulting in a hyperchloremic metabolic acidosis. This is most commonly associated with diarrhea and renal tubular acidosis. May aid in differentiating normal anion gap acidosis. The treatment of metabolic acidosis is reversal of the underlying insult, with bicarbonate therapy being reserved for normal anion gap acidosis. Dialysis is rarely required. Metabolic alkalosis. Metabolic alkalosis occurs with acid loss or bicarbonate gain. It is most commonly seen with upper GI losses, vomiting, or overdiuresis. In assessing metabolic alkalosis, urinary chloride is helpful and aids in determining if it is a saline chloride responsive or non-responsive alkalosis. Management includes normal saline resuscitation in saline responsive cases. Non-saline responsive alkalosis requires correcting mineralocorticoid excess and primary hyperaldosteronism. Respiratory acidosis. Respiratory acidosis is secondary to inadequate ventilation with resultant excess CO2. The causes are multiple to include sleep apnea, overmedicated iron, and increased respiratory workload from metabolic acidosis with exhaustion, to name a few. The management is supported pharmacologic therapies, O2 supplementation, and non-invasive mechanical ventilation, yet may require mechanical ventilation if not already in place. Respiratory alkalosis. Respiratory alkalosis is an acid-based disturbance secondary to alveolar hyperventilation with resultant hypocapnia. Etiologies include a physiologic response to hypoxia, pain, and anxiety, to name a few. Management is directed at the underlying disorder. Electrolyte abnormalities. Although a comprehensive overview of electrolyte abnormalities is beyond the scope of this chapter, a brief overview is provided here. Hyponatremia. Hyponatremia is the most common electrolyte disorder seen in the hospitalized population, including the ICU. It occurs secondary to H2O gain or salt loss. The most common cause in the hospital and ICU is the use of hypotonic maintenance solutions. This practice has been reviewed via compelling evidence in both the surgical and non-surgical populations. Additionally, ADH is released in response to stress and contributes in many patients a form of syndrome of inappropriate ADH. Diuretics also give rise to hyponatremia. Other etiologies include diarrhea, heart failure, liver disease, and renal disease. Serum and urine electrolytes and osmolality, along with the assessment of volume status, are utilized in diagnosing hyponatremia causes. Management strategies include fluid restriction alone or with a diuretic in hypovolemic states, normal saline in hypovolemic states, and treatment of the underlying etiology in euvolemic states. Correction of chronic severe serum sodium less than 121 mx/L. Hyponatremia too quickly may result in osmotic demyelination syndrome, previously known as central pontine myelinalysis. For this reason, the goal is to correct the hyponatremia no quicker than 0.5 mx/HL. Acute hyponatremia can be corrected more quickly, along with symptomatic hyponatremia resulting in seizures, which should be corrected more quickly until the seizures cease, followed by a slower correction rate. HIP-YG water losses may occur with invasive mechanical ventilation, open abdomens following damage control surgery, central or nephrogenic diabetes insipidus from loss of ADH, and insensible losses. A major symptom is thirst. Treatment is correction of the free water deficit, which is calculated via the following formula. Free HOO deficit equal to total body HOO1. Acute hyponatremia occurring within the last 24 hours should be corrected over 24 hours, and chronic or unknown hyponatremia should be corrected over 48 hours with a correction rate of no more than 0.5 mosm/L/HR to avoid cerebral edema. Other electrolyte abnormalities: hypocalcemia, hypokalemia, hypomagnesemia, and hypophosphatemia, all commonly occur in the ICU secondary to nutritional deficits and anabolic demands of a critically ill patient, among other etiologies. Hypocalcemia often does not require replacement unless clinically symptomatic. All others should be replaced per institutional practices. Hypocalcemia, hypokalemia, hypomagnesemia, and hypophosphatemia. Hyperkalemia and hypophosphatemia will be covered later under acute kidney injury AKI. Hypomagnesemia is rare in the ICU setting, with the most common cause being an excessive magnesium load in the face of renal impairment. Hypocalcemia too is rarely seen in the ICU, with the most common causes being primary hypoparathyroidism and malignancy overall. Mild cases do not require treatment, however. Severe cases with altered mental status do. Management includes volume resuscitation with balanced crystalloid solutions, along with calcitonin and bisphosphonates. Dialysis remains an option for severe cases in the setting of renal failure. Acute kidney injury AKI is a common complicant ion in the ICU. Most typically, the etiology is multifactorial to include hypotension, drugs, and infection. There have been numerous consensus definitions of AKI. The RIFLE criteria were initially proposed by the Acute Dialysis Quality Initiative and subsequently revised by the Acute Kidney Injury Network AKIN. Most recently, the Kidney Disease Improving Global Outcomes criteria were adopted as a revision of AKIN. These criteria include increase in serum creatinine by greater than or equal to 0.3 mg/dl mu epsilon gamma alpha lambda epsilon tau epsilon rho omicron eta iota sigma omicron mu epsilon epsilon iota kappa omicron sigma iota epsilon psi iota pi epsilon u tau epsilon mu mol/L within 48 hours, or increase in serum creatinine to greater than or equal to 1.5 times baseline, which is known or presumed to have occurred within the prior 7 days, or urine volume less than 0.5 ml/kg/HR for 6 hours. Once identified, one must determine if the AKI is prerenal, intrarenal, or postrenal. Prerenal causes account for the majority of hospital-acquired AKI and include hypovolemia, congestive heart failure, and decompensated liver disease. Fortunately, prerenal AKI typically does not result in permanent kidney damage. Prerenal AKI may be confirmed by a fractional expression of sodium less than 1%. Intrarenal AKI is most commonly caused by acute tubular necrosis. Etiologies of acute tubular necrosis include medications, contrast media, and sepsis to name a few. Intrarenal AKI may be confirmed by a fractional expression of sodium greater than 1%. Postrenal AKI is uncommon in the ICU setting. It is the result of obstruction to urinary flow. Evaluation includes assessment of the postrenal system in a renal ultrasound, uploaded by MedBooks and Quality of AKI. These sequelae include hyperkalemia, volume overload, metabolic acidosis, and often paired hypophosphatemia and hypocalcemia. If this is unsuccessful, dialysis may be required. Similarly, dialysis may be required to manage life-threatening sequelae. Hyperkalemia. Hyperkalemia is the result of impaired potassium expression AKI or transcellular potassium shifts. Its most critical effect is a reduction in the myocardial resting membrane potential with conduction system abnormalities. EKG findings include PT waves, most common finding, widening QRS complexes, loss of P waves, sine wave, ventricular arrhythmias, and ultimately asystole. In managing hyperkalemia, it is most critical to prevent life-threatening arrhythmias. Measures include counteracting potassium's effect at the cellular level, shifting potassium to the intracellular space, and removing potassium from the body. Calcium chloride 1 gram is used to antagonize hyperkalemia-induced arrhythmias, while insulin 10 units increases the cellular uptake of potassium. It is the most successful agent at shifting potassium to the intracellular space. Insulin must be followed by dextrose to avoid the resultant hypoglycemia. Additional agents that shift potassium to the intracellular space are nebulized albuterol and sodium bicarbonate. All of these maneuvers are temporizing, so measures to remove potassium from the body must be employed likewise. Sodium polystyrene sulfonate KXLate exchanges sodium for potassium in the colon and effectively removes potassium from the body. That being said, it requires 24 hours to do so. 1 gram of KXLate removes 1 mg of potassium and has been associated with intestinal necrosis and bowel perforation. Newer agents Patermer and sodium zirconium cyclosilicate are on the horizon. However, they are not fully vetted as of yet. Dialysis remains the gold standard for potassium removal from the body. It should be used liberally when indicated. Volume overload. AKI and volume overload are intimately related. As such, the pulmonary status of patients in AKI must be closely watched, and endotracheal intubation may be required. The management of such overload includes diuretics if the patient is still producing urine or, more commonly, dialysis. Metabolic acidosis. The kidneys function in excreting acid and generating bicarbonate may be impaired, leading to significant acidosis, in addition to the effect of the underlying insult that caused the AKI. While bicarbonate therapy serves as a temporizing maneuver, dialysis should be considered definitive therapy. Generally, treatment is deferred unless the pH drops below 7.1, at which point there is risk for serious metabolic effects such as left ventricular depression and hemodynamic instability. Hypocalcemia and hypophosphatemia. The kidney's ability to excrete phosphorus is impaired in AKI, leading to hypophosphatemia and resulting hypocalcemia. The hypocalcemia should be repleted only if the patient is symptomatic. However, if the patient's hypocalcemia is secondary to hypophosphatemia, calcium administration may cause metastatic calcificant ion, a devastating complicant ion. Typically, dialysis is the hemorrhagic system. Thrombolystography. TG was devised in the 1950s to assess the clotting capability of whole blood. Despite its potential applications, its widespread use was limited by lack of accessibility and complexity in testing, and so the more common and conventional coagulation tests such as PT/INR, partial thromboplastin time PTT, platelet count, and fibrinogen level were preferred. It was not until the 1980s when testing became more practical, quicker, and reproducible that TG was used to guide resuscitation during transplant and cardiac surgeries and was found to decrease the total administration of blood products and mortality. Treating patients with various hemorrhagic abnormalities ranging from acute hemorrhage to thromboembolic disease requires an intimate knowledge of the clotting cascade and objective data to be able to assess where deficiencies or abnormalities exist in order to maintain the delicate balance between coagulation and fibrinolysis. While the basic tests of coagulation provide information regarding the quantity of coagulation factors, they do not assess the quality and functionality of those factors. Thromboelastogram provides a functional assay of clotting and clot lysis that can be used to guide resuscitation and treatment efforts. There are 3 phases of coagulation that are measured with TG: clot initiation, clot strength, and clot stability. Figure 22.2. The test begins by exposing an aliquot of whole blood to an activator, which induces the clotting cascade. The time required for the first evidence of clot formation is measured as the R time. Fibrin cross-linking propagates clot enlargement, and the time required to form 20 millimeters of clot is defined as the K time. The rate of clot enlargement is the alpha angle, measured as the tangent to the curve of the TG tracing as the K time is reached. Platelet aggregation continues, and the widest part of the TG tracing represents the point of maximal clot strength, termed the maximum amplitude. The assay continues for an additional 30 minutes, and the degree of fibrinolysis is measured as a percentage of clot lysis LY30. Alterations in the R time, K time, alpha angle, maximum amplitude, and LY30 result in varying TG tracings that correspond to coagulation abnormalities that can be treated with transfusions of either FFB, platelets, or cryoprecipitate. It is insufficient to rely upon the basic hematologic assays of PT, inner, and PTT when assessing a patient's overall coagulation status, as these tests do not provide information on the quality of coagulation factors nor what factors in the clotting cascade are deficient or altered. Thromboelastogram provides a reliable functional assay of coagulation that identifies the specific phases of coagulation that are altered and can be improved. It also accurately predicts the need for transfusion for the first 24 hours after a penetrating injury, as demonstrated by Plotkin and colleagues. Beyond the ability to guide resuscitation, additional consideration must be placed into the time necessary to obtain a test result. A standard PT, inner, PTT, and platelet count require roughly 45 to 60 minutes due to logistic restraints of a hospital laboratory, while the initial results from a TG require only 10 to 15 minutes and can often be examined real-time. Because a TG study provides real-time data for various phases of coagulation, preliminary results can be obtained early while awaiting the full testing results. Fig. 22.2 diagram of thromboelastography, thromboelastogram tracing, and its relation to the clotting cascade. Adapted from Hagner SG, or also A. Bleeding disorders. N. Silverstein DC, M.A. Maximum heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia, HIT, is a life-threatening complicated ion that occurs in a small percentage of patients exposed to any of the forms of heparin. There are two types of HIT that are distinguishable based on timing and degree of thrombocytopenia and can be confirmed with laboratory testing. Type 1 HIT is a mild, transient thrombocytopenia that affects approximately 10% of patients within 2 days of heparin exposure. Thrombocytopenia occurs due to a non-mu-mediated direct effect of heparin on platelets, causing aggregation. Platelet counts typically nadir at approximately 100,000/μL and recover to normal levels without intervention. Type 1 HIT generally has no clinical significance, does not cause thrombosis, and is managed expectantly. Alternatively, type 2 HIT is a serious and life-threatening immune-mediated thrombocytopenia that affects 1% to 5% of patients exposed to heparin. Heparin will bind to circulating platelet factor 4 molecules and form immunogenic complexes that can be bound by immunoglobulin G antibodies. These immune complexes release additional prothrombotic molecules, thus propagating platelet consumption. The reticuloendothelial system eliminates these circulating immune complexes, leading to thrombocytopenia. Studies demonstrate that 20% to 68% of patients who develop type 2 HIT will also have arterial and venous thromboembolic events. The degree of thrombocytopenia seen with type 2 HIT is more pronounced, with a roughly 50% decrease in platelet count and nadir approaching 50,000/μL. The development of type 2 HIT usually occurs approximately 5 to 7 days after heparin administration or sooner if there is prior heparin exposure. There are many potential etiologies for thrombocytopenia in an ICU patient, but when there is clinical suspicion for HIT, further investigation is warranted. The 4TS score is a quantifiable clinical assessment tool providing a pretest probability for the presence of HIT. Factors assessed include the degree of thrombocytopenia and platelet nadir, timing of thrombocytopenia after heparin exposure, presence of thrombosis, and the possibility of alternative etiologies for thrombocytopenia. Laboratory assessment for HIT generally begins with an enzyme-linked immunosorbent assay ELISA, which is sensitive but not specific for HIT, and a confirmatory assay such as the serotonin release assay. Although serotonin release assay is considered the gold standard, it is not as readily available and requires testing in a reference laboratory. Patients at moderate risk for HIT based on the 4TS score should have all sources of heparin discontinued. Start on enrollment for a direct thrombin inhibitor unless there are relative contraindications, and have an ELISA assay obtained. If the ELISA is negative, then the direct thrombin inhibitor is discontinued unless the probability of HIT has increased since the ELISA assay was sent. Patients at high risk for HIT are also started on a direct thrombin inhibitor, but even if an ELISA is negative, they are presumed to have HIT until a confirmatory serotonin release assay is obtained. Over 40% of patients in the ICU develop thrombocytopenia, but HIT is rarely the cause, with an overall incidence of only 0.02% to 0.45%. Despite its rarity, even with treatment, mortality rates associated with HIT can be as high as 14.5% to 25%. In any patient with clinical suspicion for HIT, it is prudent to avoid all heparin exposure until a definitive diagnosis is obtained. Venous thromboembolism. Critically ill patients are at high risk for developing venous thromboembolism VT as they have all the components of virtue tried to some degree: endothelial injury, venous stasis, and hypercoagulability. VT is a preventable cause of death that is common but often undiagnosed and clinically silent. All patients admitted to the ICU should be assessed for and treated against the development of VT as recommended by the American College of Chest Physicians' evidence-based clinical practice guidelines, and yet approximately 40% of patients at risk of VT remain untreated. Most cases where thromboprophylaxis is held is due to physician perception that the risk of bleeding outweighs the risk of VT. However, delays over 24 hours in initiating pharmacologic VT prophylaxis after ICU admission are associated with a threefold increase in VT formation after major trauma. Omission of thromboprophylaxis after 24 hours conveys an attributable mortality of approximately 3.9% to 15.4% in patients with major trauma, sepsis, cardiac arrest, or heavy cancer burden. Data and statistics from the Centers for Disease Control and Prevention convey the significant morbidity and mortality of VT. Approximately 10% to 30% of patients with VT die within 1 month. Long-term complications of swelling, pain, and discoloration of the affected limb. Absolute contraindications to chemical thromboprophylaxis include active bleeding or intracranial hemorrhage, coagulopathy, and severe thrombocytopenia. However, in patients with relative contraindications such as recent GI bleeding, recent surgery, and moderate thrombocytopenia, the decision to initiate chemical thromboprophylaxis must be made on a case-by-case basis. At a minimum, mechanical thromboprophylaxis should be provided by means of intermittent pneumatic compression devices. Mechanical compression is used to promote venous blood flow and is thought to activate tissue plasminogen and local fibrinolysis. When no absolute contraindications are present, chemical thromboprophylaxis should be administered as it is proven superior to mechanical compression for the prevention of DVTs and Ps. Low molecular weight heparin is shown to be more effective than unfractionated heparin for the prevention of DVTs, but is renally excreted and should not be used in the setting of AKI or renal failure. Despite adherence to chemical thromboprophylaxis administration, Obesity and pro-inflammatory states such as sepsis convey higher rates of VT prophylaxis failure. In these cases, goal-directed therapy and titration of low molecular weight heparin dosing based on anti-Zal levels have been proven effective. In patients in home, chemical thromboprophylaxis is contraindicated for an extended period of time. One must consider placement of an inferior vena cava filter to prevent large DVT embolization and clinically significant PEs. Hemoglobin transfusion strategies. Along the same lines as antibiotic stewardship, the good faith practice is required when deciding to transfuse a patient. Although guidelines exist, they are not intended to replace clinical judgment and do not apply universally to all patients. Along with hemoglobin level, other factors to consider regarding the need for transfusion include the rate of hemoglobin decline, overall volume status, tachycardia or hypotension not responsive to fluid administration, and subjective findings of shortness of breath, lightheadedness, and chest pain. Currently, the American Association of Blood Banks (OB) strongly recommends a restrictive transfusion threshold of a hemoglobin level of 7 grams/dl for all hemodynamically stable patients, including the critically ill. A slightly more liberal transfusion threshold of hemoglobin level of 8 grams/dl is recommended by the OB for patients undergoing orthopedic or cardiac surgery. A recently released multicenter trial examining 5,243 adults undergoing cardiac surgery showed that a restrictive transfusion threshold of hemoglobin level of 7.5 g/dl was not inferior to a more liberal threshold of 9.5 grams/dl. When transfusing PRBC, standard practice is to transfuse 1 unit of PRBC with a recheck of hemoglobin prior to transfusing further. It is also important to note that transfusion-related complications are not infrequent to include allergic or anaphylactic reactions, fluid overload, iron overload, transmission of blood-borne infections, transfusion-related acute lung injury, immunosuppression, hypersensitivity reactions, and life-threatening hemolysis from ABO incompatibility. Endocrine system, glucose control. Hyperglycemia in severely ill patients was originally thought of as an adaptive response to critical illness but has since proven to be. Many factors, including glucose production and release in response to catabolic hormones and accompanying insulin resistance. Hyperglycemia is an independent risk factor for adverse outcomes after trauma, sepsis, and TBI, as it is associated with increased rates of infections, a state of immunosuppression, and resulting organ dysfunction. Conversely, tight glycemic control in the ICU setting can be difficult to maintain, especially in patients with variable caloric intake, and can easily lead to severe hypoglycemic episodes resulting in stupor, coma, seizures, and neurologic injury. While the optimal glucose target range is still up for debate, there are numerous studies proving that tight glycemic control is associated with worse outcomes. As was demonstrated by the Nice Sugar trial, patients managed with tight glycemic control between 81 to 109 milligrams/dl as compared to a more conventional glucose target goal of less than 180 milligrams/dl were found to have a statistically significant increased 90-day mortality rate. Rates of severe hypoglycemia glucose level less than 40 milligrams/dl occurred in 6.5% of patients within the tight glycemic control group as opposed to 0.5% of patients with conventional glucose management. Subsequent studies have since confirmed the dangerous effects of tight glycemic control in the ICU, and a more liberal and attainable glucose target of between 140 and 180 milligrams/dl is now the standard of care. Adrenal insufficiency. Critical illness related corticosteroid insufficiency occurs when a patient is unable to generate sufficient corticosteroids to compensate for the severe stress and shock state they are experiencing. Severe trauma, sepsis, and the significant metabolic demands of critical illness lead to upregulation of the hypothalamic pituitary adrenal axis in an attempt to increase corticosteroid release. However, when these demands are not met, the patient will remain hypotensive and unresponsive to fluid or vasopressor administration. The most severe cases of critical illness related corticosteroid insufficiency can be seen secondary to adrenal hemorrhage in the setting of trauma, burns, thromboembolic disease, coagulopathy or sepsis, and secondary to pituitary apoplexy from sudden necrosis of pituitary tumors. The use of steroids for treatment of refractory shock began as an anecdotal finding with minimal corroboration. However, the Corticus trial demonstrated that corticosteroid administration had no effect on survival or reversal of shock in the setting of sepsis, but did quicken shock reversal in patients who recover. While the quality of evidence is variable, current recommendations are for corticosteroid administration in the form of hydrocortisone when a patient is unresponsive to vasopressin when they are volume replete. For patients with chronic, long-term steroid use, equivalent Roman 4 dosages should utilize until the patient is able to resume oral intake. As these patients have no intrinsic corticosteroid production, exogenous administration is necessary to prevent an Addisonian crisis. Thyroid dysfunction. Dysregulation of the thyroid gland and thyroid hormone production in the setting of critical illness can have systemic consequences that can be fatal if not promptly recognized and treated. Thyrotoxicosis due to Graves' disease, a toxic nodular goiter, or toxic adenoma can precipitate into a thyroid storm in the setting of acute trauma, critical illness, infection, iodine contrast administration, and megacation reactions. Thyroid storm is a very rare and feedback mechanisms become altered and ineffective. Clinical manifestations include altered mental status, anxiety, high fevers commonly up to 105 degrees Fahrenheit, tachycardia, tremors, and GI dysfunction including nausea, vomiting, and diarrhea. Severe forms can result in seizures, coma, atrial fibrillation, heart failure, and hepatic dysfunction. The diagnosis of thyroid storm is based on clinical evidence and laboratory evaluation demonstrating suppression of thyroid-stimulating hormone and elevation of free thyroxine and /or triiodothyronine. Grading scales to predict the presence of thyroid storm do exist, but the clinical manifestations can be very nonspecific with innumerable etiologies. As such, a high index of suspicion is required to diagnose thyroid storm to include patients with very high fevers. Of note, establishing an underlying diagnosis for the cause of thyroid storm should not delay treatment. When thyroid storm is suspected, treatment should be started immediately and is focused on minimizing the clinical manifestations and decreasing thyroid hormone production. Beta blockers such as propranolol or esmolol control the tachycardia and hypertension and reduce anxiety. Thionamides such as methimazole or propylthiouracil inhibit new thyroid hormone synthesis, and when not contraindicated, propylthiouracil is preferred as it also decreases peripheral conversion of thyroxine to the more active triiodothyronine. Iodine is then given as potassium iodine or Lugol solution to inhibit thyroid hormone release, but must be delayed 1 to 2 hours after thionamide administration to prevent the iodine substrate from being used for new thyroid hormone synthesis. Glucocorticoids can also be given to decrease peripheral conversion of thyroxine to triiodothyronine and may help treat an underlying Graves' disease as the cause of thyroid storm. Patients who fail medical management or have contraindications to thionamide should undergo therapeutic plasma exchange or surgery for definitive treatment. Infectious diseases. General principles. One of the greatest challenges to diagnosing and treating infections in the ICU is that findings classically associated with infection are not or quite non-specific in the ICU setting. For example, an elevated white blood cell count or fever may simply be secondary to a postoperative or post-injury inflammatory response. Conversely, a normal body temperature may not be reassuring, as patients undergoing continuous renal replacement therapy, those on ECMO, or those with large surface area burns may not manifest a fever. Additionally, other non-specific findings may portend an untreated infection, such as a no-onset ileus representing an intra-abdominal source of infection. Ultimately, clinical judgment is key. As for the optimal processes for evaluating a possible infectious etiology, there are no widely agreed upon guidelines regarding the optimal indications and timing for cultures. Much of this has to do with the lack of meaning of blanket or pan cultures, with the majority of blood cultures obtained being negative. With regard to the evaluation and management of sepsis, most institutions have enacted sepsis protocols. Such systems, along with astute clinicians, are critical, seeing as the early suspicion and diagnosis of sepsis and the prompt administration of antibiotics convey a significant mortality benefit. Additionally, critical is adequate source control. In all cases, broad-spectrum antibiotics should be administered while awaiting source control with source in the local/institutional antibiogram. Central line, associated bloodstream infections. CLABSI are a source of significant morbidity and mortality in hospitals and are the most expensive of all healthcare-associated infections, accounting for approximately $46,000 per case. By definition, a CLABSI is a laboratory-confirmed bloodstream infection in a patient with a central line, where the cultured organism is unaffiliated with an infection from a different site. As most critically ill patients with central lines have many other possible infectious sources, one must be keenly aware of the central axis that a patient has and its possibility of infection. In situations of concern, one may simply observe the patient, obtain appropriate blood cultures, or remove the central line, among other options. If the line is to be removed, catheter tip cultures are not to be obtained, as they are often misleading. Once diagnosed, the mainstay treatment for CLABSI is line removal and antibiotic therapy. That being said, the specifics are poorly established. Attempts at catheter salvage with antibiotics alone are not recommended in the critically ill population. Empiric antibiotic therapy should be initiated upon suspicion and continued until cultures return negative or de-escalated based on antimicrobial susceptibility. The duration of treatment varies by organism and ranges from 7 days to 6 weeks. That said, the best treatment for CLABSI is prevention. Most effective is strict aseptic technique to include proper hand hygiene before and after insertion, full barrier precautions during insertion, and 2% alcoholic chlorhexidine used for skin preparation. Avoidance of the femoral vein site and the prompt removal of unwarranted lines are also critical. Catheter-associated urinary tract infections. Urinary tract infections (UTIs) are the most commonly reported healthcare-associated infection. Approximately 75% of these are catheter-associated UTIs (CAUTIs). Technically, a CAUTI is a UTI in which the positive urinary culture is from an indwelling urinary catheter that has been in place for more than 2 calendar days. Similar to CLABSI, CAUTI in the ICU often present with vague symptoms and can be challenging to diagnose. Many symptoms/signs suggestive of a UTI, such as penile pain, purulea, and bacterial growth, may be found normally with colonized Foley catheters. However, the absence of purulea and bacterial growth strongly suggests against the diagnosis of CAUTI. The diagnosis of a CAUTI is per urinalysis and urine culture with 105 coloniforming units. The management of a CAUTI includes initial empiric antibiotics, replacement of the catheter, and supportive measures. Subsequently, antibiotics are de-escalated based on culture and sensitivity testing. Optimal duration of treatment is not firmly established, yet 7 to 14 days is widely accepted based on the organism. As with CLABSI, the best treatment of CAUTI is prevention. This includes the use of sterile technique on insertion of urinary catheter and aggressive attempts to remove the catheter as soon as possible. Intermittent straight catheterization is another option to consider in place of Foley catheters in certain patient populations. Diarrhea and Clostridium difficile. Diarrhea in the ICU setting is not terribly uncommon, often secondary to enteric feeds or iatrogenic secondary to motility agents. Over the years, many factors such as antibiotic exposure, older age, and recent hospitalizations increase the risk for patients to develop C. difficile diarrhea. Misrating for C. difficile infection. A thoughtful approach is key. Indications to sample include 3 or more watery stools in 24 hours, with significantly increased ostomy quantity and output, no laxatives or bowel regimen for the prior 48 hours, and not having tested for C. difficile or a positive test within the past 7 days. The management of C. difficile is comprised of discontinuing any antibiotics if possible, avoiding antimotility agents, and an appropriate antibiotic regimen based on if this is an initial bout or recurrence. Initial bouts of initial recurrent in severe cases. The severe metabolic while C. diff patients should be in immunocompetent. Other common infectious issues in the ICU: intra-abdominal infections. In surgical ICUs, a common infectious etiology is an intra-abdominal infection secondary to a multitude of sources. If a generic patient has persistent fevers and leukocytosis, but no obvious source of infection, a CT of the abdomen and pelvis should be considered to assess for an intra-abdominal source. Similar to aforementioned, the mainstays of therapy are source control and antibiotics, with antibiotic therapy being dependent on the exact source, the risk level of the patient, and the possibility of the infection being hospital-acquired. Recent extrapolated data suggests that antibiotics for intra-abdominal infections can be discontinued 4 days after source control has been achieved, as there is no benefit to a longer duration. Thrombophlebitis. Superficial venous thrombus and infection are not infrequent in the ICU, most commonly being related to Roman 4 catheterization. Treatment is removal of the Roman 4, elevation of the extremity, warm compresses, and possibly a non-steroidal anti-inflammatory agent. Antibiotics are not routinely indicated. In severe cases, excision of the vein for source control may be required. Special issues. The open abdomen. The open abdomen is not commonly found in the ICU. It results from several situations, most commonly damage control, ill but require urgent surgery to control traumatic hemorrhage, abdominal sepsis, etc. Are taken to the operating room. There, the surgeon performs life-saving maneuvers, i.e., control of hemorrhage, control of hollow viscous injuries, shunting of critical vascular injuries, etc., and brings the patient to the ICU with a temporary abdominal closure. In the ICU, the goal is to return the patient to normal physiologic status to include correction of coagulopathy, hypothermia, and acidosis. Once stabilized, the patient returns to the operating room where definitive repairs are performed. Abdominal compartment syndrome is a potentially lethal condition caused by an inciting event that yields intra-abdominal hypertension and resultant organ dysfunction, i.e., decreased lung compliance, decreased urinary output, decreased venous return to the heart, etc. The definitive treatment being a decompressive laparotomy, the abdomen left open, and a temporary closure. Patients in the ICU with an open abdomen require special attention. Volume management is per routine. However, one must be cognizant as to potential fluid losses from the open abdomen and assure appropriate replacement. Contrary to popular belief, patients with an open abdomen do not need to remain intubated and on the mechanical ventilator, provided they are otherwise physiologically stable. Most commonly, patients with an open abdomen are managed with vacuum-assisted closure therapy. This provides a temporarily closed environment where negative pressure is applied to the wound. Such systems are changed at 48-hour intervals until the abdomen is closed. Failure of the vacuum-assisted closure therapy system often requires replacement either at the bedside or in the operating room. A concept gaining traction for severe abdominal trauma and its resultant inflammation is direct peritoneal resuscitation. This modality involves continuously bathing an open abdomen with what is essentially peritoneal dialysis fluid. In several studies, this technique has been documented to decrease the inflammation and abdominal complications but has not shown any survival benefit. Palliative care. As the population ages and medical technologies improve, especially the life-sustaining efforts of the ICU, the management of end-of-life issues, it is a crucial skill set for the surgical intensivist. Palliative care is the multidisciplinary approach to those patients with life-threatening illnesses. This includes pain and symptom management, psychosocial support, planning beyond the immediate hospitalization, etc. As such, its integration into the ICU is critical. That being said, such integration is often easier said than done. Transitioning from a curative to a palliative mode is challenging and requires excellent communication with the patient's family, and the care team. Multisystem organ failure and futility. Multisystem organ failure, also known as multiple organ dysfunction, involves altered organ function in a critically ill patient and carries extremely high morbidity and mortality. The management includes that for the failing systems, inotropes, intra-aortic balloon pumps, left ventricular assist devices for heart failure, mechanical ventilation for acute respiratory failure, continuous renal replacement therapy or dialysis for AKI, etc. While there is no widely available liver replacement therapy, in certain pediatric populations, molecular adsorbent recirculating systems are being used. It is imperative to realize that as the number of organ failure, as multisystem organ failure develops and progresses, it is critical to have candid conversations with the patient's family. Although these discussions are difficult and nuanced, if performed well, the patient's family and care team can often come to a resolution that has the patient's best interest in mind. In instances where the patient's management is without benefit and potentially inflicting pain and prolonged suffering, it is even more critical to engage in such conversations. Such conversations of futility are the most challenging of all. Medical futility refers to interventions that are unlikely to yield any sort of benefit to the patient. Such determination is ethically challenging and, as such, controversial. Engaging local experts to include palliative care specialists and the hospital's ethics committees can be quite beneficial and is recommended. Critical care physicians need to be intimately involved in such processes and also in setting institutional and governmental policies in this arena. Selected references: Whole kilometer, Chavin S., Pilcher D. Omission of early thromboprophylaxis and mortality in critically ill patients, a multicenter registry study. Chess, 2011, 140th, 1,436, 1,446.